applicable. And in the true spirit of collaboration, I did speak to colleagues who I wish to acknowledge at this point. On the left are pediatricians and neonatologists, some in Kenya and some in the United Kingdom, as well as on the right, obstetricians who are very familiar with the obstetric and neonatal service delivery system in Kenya. Thank you. Next slide. When I was looking at the problem of collaborative working, I usually like starting with a mind map, and I asked myself some key questions. If we are going to go in a clockwise manner, I wanted to define what is collaborative working, why is collaborative working important, where does it apply in as far as obstetric and neonatal practice is concerned, who does it involve, when is it applicable, and how do we make sure that we apply it. Next slide. Next slide. So I found a very good definition from the World Health Organization framework for action on interprofessional education and collaborative practice. And it defines collaborative practice in healthcare as when multiple health workers from different professional backgrounds provide comprehensive services by working with patients, their families, carers, and communities. It also emphasizes that the scope goes beyond the clinical cadres that we know. It also involves non-clinical health-related workers. So we are thinking of the person who transports the patient, for example, from ED to the labor ward, the person who is feeding the patient, the person who is cleaning the floor. All those people are making contributions, and they are part of collaborative practice. Next slide. The Sullivan et al. Did define the elements of collaborative working, and I would like us to reflect on our own situation as I go through these key buzzwords. The first one is coordination, and it's coordination to achieve shared goals. Cooperation, that means contributing to the team, understanding and valuing the contributions of all the team members, from the person who cleans the floor to the to the topmost consultant in the unit or the manager. And then there's shared decision making, looking at negotiation, communication, openness, trust, and respectful power balance. And then partnerships, which should be open, respectful, and cultivated over time, in which all the members work equitably together. Next slide. Next. When I was thinking who is to be involved in collaborative working, I decided to draw this schema. In the middle there, you'll see a mother, her baby, and the partner. And then around, that's on the second left-hand side diagram, there are obstetricians, there are midwives, there's a neonatologist, and then there are other, in the lower circle, other providers, the primary care doctors. I know in Kenya, we don't have a very established primary care system that involves like a GP when I compare with the UK, but I am sure it's coming up. I have heard of family medicine physicians. We have physicians, we have surgeons, we have other allied health staff, the blood transfusion guy, the physiotherapist, the nurses. We have social services who we occasionally have to consult when we are dealing with complex social situations. And we have the partner of the mom and the family. All those are involved in collaborative working. And I like viewing it as the center of this is the patient, the mom and her baby. On the right-hand side is the evidence-based medicine triad that was coined by Professor David Sackett. And he did define evidence-based practice as individual clinical expertise, which is what we provide, then best evidence, which is what research informs us, and patient values and expectations, all of them meeting somewhere in the middle and then contributing to the overall being of the mom and the baby. Next. My college does define the characteristics of collaborative working. So it's not just my college, but also the Royal College of Midwives together. And I would like you to pay attention to the buzzwords that I have circled. The first one is one voice. So when there's collaborative working, there's one voice. People are speaking with one voice. They are united in their goal, so they have to define what goals they want to achieve for them to then get united. They must share a vision. They have to have a common purpose in supporting best practice. There has to be mutually respectful relationships. There has to be strong leadership and followership, if I can extend. And then the woman's voice and needs are at the center of her care. And the last two are respectful team working and supportive workplace cultures. So quite complex things which we need to reflect upon. Next. And why are we talking about collaborative working? Why is it necessary? On the right-hand side, Molly et al. Did do a write-up on the benefits of collaborative working. One is quality of care. We are always talking about quality of care, both for obstetrics and neonates, patient engagement benefits, patient safety, and then, of course, staff and organizational benefits. When you're going to ask KNH or UoN to fund something that contributes to collaborative working or going to approach a partner, then you can draw a plan and tell them, hey, it's also going to benefit you. On the left-hand side is a schema again that I drew, if we can take a clockwise approach. Key in it is maternity safety. And when we have collaborative working, we are more prepared for events, we have become more aware, and therefore we make less errors. And the effect is that we'll have less maternal morbidity and mortality and less neonatal morbidity and mortality. We will also decrease litigation risk. It's quite common where I am. The specialty that has the greatest value of litigation in terms of millions of pounds is obstetrics. So this is very key to us. And obviously all of us come to work wanting to make a difference and wanting to be happy and get fulfillment. So collaborative working will enable that. Next slide. Now, what makes collaborative working work and what hinders it? Next slide. On the left is the drivers as outlined by Molly et al. The first thing is content. They've classified it into three themes, yes, content, processes, and internal driven actions. In content, we are thinking about team vision and strategies. People must find identity within this team vision. The second thing is processes, such as organizational structures, which facilitate collaborative working. And the third point, which to me is very important, is values and motivation. Because values and motivation, Professor Ndwati, your hand is up. Did you want to say something?
No, just continue. Just sorting out something. That's fine. Thank you.
Thank you. All right. Values and motivation. You know, when we come to work, it has to be why you're coming to work. Sometimes you are faced with very difficult circumstances, yet you still come to work because deep down, it's your values that are driving you. But if you go on to motivation, those are the things like benefits you're getting from it, the money, the fame, and all that, then those two drive us towards different directions. So for collaborative working to work, then your values must be stronger than your motivations. On the right-hand side is barriers. And these are factors that are beyond the control of the team. For example, compensation schemes, who is going to fund all these activities that are involved in collaborative working, professional practice regulation, institutions themselves can be barriers, physical environment factors. I was thinking of the situation of overcrowding in the wards and all that, and very high volume of patients and systems which are not streamlined in terms of triage and referrals. Although I was happy to read in the media that soon Kenyatta will be a referral-only facility, although I hope not for obstetrics, and because I have a different view that mothers should be able to access their care wherever they are. So I do hope that obstetrics and neonatology will get exemption from that policy of just being referral-only. Then team members with different interests, goals, expectations, styles, and experiences that contributes to our values and motivation. Those can be barriers in as much as they can be strengths. Then we have people of varying education, varying roles and responsibilities, authority. This is where we think about the power distance. And if I can compare my experience back in Kenya and the United Kingdom, the power distance is a very important factor. In Kenya, there's a high power distance. That means that the more senior you get, then the juniors are unable to approach you to discuss issues to do with patient care openly. And, whereas over here, I am able to ask Professor, why have you advised on this and not the other line of management? And the professor will not feel offended. So high power distance is not good for collaborative working. We need to narrow the gap. It's also not good for learning. A shorter power distance is better for learning. Next slide. To go on to elements of collaborative working by Molly et al., I'd really encourage you to look at that paper. It was quite interesting. The opportunities for collaborative working, we are thinking of time, space, tools. By tools, we think of the things that make things happen and procedures. Then ability comes down to the individuals and then spreads out to the teams. And then willingness, that we must all be willing to focus on safety. Any decision we make, if you're called to the labor ward to review or speak to a mom, don't think about yourself first. Think about safety for that neonate or safety for that mother. So that should be top on every decision that we make. You are late to go home, it's past your shift, but there's a mom there who you might make a difference. Safety first. Collegiality is the thing of treating each other as colleagues. I encourage us to think of our job titles, of our, the way we say consultant and professor as job titles. They do not necessarily mean that we have the best answer for the problem at hand. Sometimes the most junior, most person in the team has the best answer to the problem at hand. So we think of this as job titles and not things to shove around as authority, because that minimizes collaborative working effectively. Next slide. These are just conceptual models. On the left is 3 different teams. You can think of obstetrics, midwifery, and neonatology, and how they talk amongst one another, and the work is flowing between them. That's a conceptual model. And then on the right-hand side is conceptual relationship between learning and collaboration. The key thing I wanted to highlight in this conceptual model is sharing. So we must create an environment of where we are able to share with one another openly at all times. Next slide. For those who are in administration and wondering how do we measure where we are with collaboration, and if we implement anything, how do we assess whether there's improvement? Then there are tools that have been tested elsewhere. And of course, this is also a question for the academics with us, because you may want to then validate these tools in your own setting. So have a look at the Molly paper. They have nice references to each of these instruments and where they are. Next slide. Then where and when should collaborative working take place? Next slide. So I thought of the continuum from antenatal to intrapartum to postpartum, and then the aspect of clinical governance. If I think antenatally, when should obstetrics and neonatology work together? When you get a fetal anomaly on the ultrasound between 18 and 22 weeks, that is time to phone neonatology, discuss with the neonatologist what is the care plan for this baby. In Kenya, we don't have fetal surgery, but I am very optimistic it's going to come in. In the United Kingdom, we are doing a bit of fetal surgery where some of these conditions can be optimized. So in Kenya, it's really planning. Where will this baby be born? When will it be born? Who are the staff that will be there to support it? What do we need to support the baby who has fetal anomalies? And then counseling parents. It's very difficult when a baby has anomalies. So involving the neonatologist right from the beginning when the anomaly has been diagnosed, not a surprise on the delivery suite when they're on call. They're able to write and put a plan that others can follow later. Then, of course, health promotion spreads across. Neonatal alerts are things we do quite a lot. When you see a mother with medical problems in pregnancy with certain medications that may affect the baby at birth, we then do a neonatal alert. It's really a form that we fill either online or on paper, and then that is taken to the neonatal department. When the baby is born, the team on call can refer on to that alert where the consultant has given some input of how that baby should be managed. Then delivery planning, with the obstetricians, we do cause iatrogenic preterms. So if we involve the neonatology team in planning that, then we have better outcomes. Things like intrauterine transfer, it's better to transfer babies in their moms. That's a natural incubator to the place of safety where they will find the specialist and the equipment that will be able to support the baby. Things like safeguarding, we do have women with complex social needs where we know that if their baby is born and they go home, this baby will be at risk, they will not thrive. They will be coming to an environment full of drugs or alcohol or domestic violence, or they are at risk of having FGM. So we do involve the neonatologist who then pass on the information to the pediatrician and the social worker, social system to be able to support the parents. Intrapartum, it's all about forward planning. When you come to the delivery suite and you can see mothers who have conditions where their babies might be compromised. So it's good to, when you do the handover, when you do the rounds as part of the plan, is to alert the neonatal team that there's this baby and we would like this kind of cadre of neonatal specialists to come to the unit. Then any emergency sections, assisted vaginal deliveries that could potentially go wrong, we need to involve the neonatal team. Early initiation of breastfeeding, and again, health promotion. Then in the immediate postpartum period, there are many things we can do. I thought about diabetes. If we don't tell the neonatal team that the mom has diabetes, then they will not be able to monitor sugars in the first 2 hours, and the baby might end up having hypoglycemia and brain damage. If we don't tell the neonatal team that there was prolonged SHROM, that the mother has the risk of group B streptococcus, that the mother had intrapartum fever, then they will not be able to intervene appropriately. Then clinical governance, I think you can move on to the next slide. It has a bit of clinical governance. These are the things that that at least are best done together between the two units. I'm thinking of the pillars of risk management, education, CPDs, like we are doing today, information passing to teams and to moms, staff management, audits, and looking at patient experience and involvement. It's a system for continually improving the quality of care and safeguarding high standards. And it really involves doing the right thing at the right time by the right person. It's really the system that enables us to maintain accountability to one another, to the institutions, and to the patients that we serve. Next slide. Next slide. I'm going to borrow examples from our setting now, and then I will then at the end give you examples of things you can do at home. So one is how can you work together? If there's a common problem you've identified, for example, yesterday we were seeing the problem of birth asphyxia, then I expect the teams to come together and sit and develop a guideline and interventions that can then be used to turn the situation around. So co-designing and implementing interventions. If there are morbidity and mortality meetings, they should be, you should be going there together to learn and see the points. Deciding how you will make your service safe, depending on the challenges you're facing, that should be, again, an opportunity for collaboration. Teams that train together, work together well, so teamwork training, other soft skills that improve our well-being. As a doctor, it's not just about the knowledge and the ability to do things. It's a soft thing that make us good human beings, and that we need to pay attention to right from the training. So situational judgment, human factors, and non-technical skills. Then focusing on communication around emergencies, debriefing staff after an adverse event and the patients. Appreciative inquiry is very important. It's very tempting for somebody to just come and shout, why was this not done? Instead of starting by appreciating the team for what they did well, So in collaborative working, if you start by appreciating what has been done well, then you achieve better. And then instead of critique, you ask the team, what do you think you could have done better? Making the people identify the strengths and the gaps by themselves. And then symposiums like this one, journal clubs, skills drills, workshops, all those are important for collaborative working. Whenever there are global recommendations from World Health Organization or from others who have faced similar challenges like you're having ahead of you, then you learn from them. A good example, when I was reviewing maternal deaths, I saw that between 1900 and 1930, United Kingdom had 488 per 100,000 maternal deaths. Sadly, that is where the most of the countries in the low and middle income countries are. So instead of spending time about 100 years trying to learn and reinventing the wheel, just see what United Kingdom did and then try to customize it to your setting. If that is too far, you can look for a country that is near you, for example, South Africa or Namibia or Botswana, that seems to be having lower rates of the problems that we are experiencing, and learn from them and then translate into local. Yeah, because catching up 100 years will be a very tough job. So next slide. This is an example of the WHO recommendation on born too soon, the global action report. So it does have recommendations on the place of delivery, who should attend deliveries, essential newborn care, and CPAP. So when such reports come up, then you come together and you look, how can we then adapt this to our setting? Next slide. Next slide, please. This is in the United Kingdom, we have something called the Saving Babies Lives Care Bundle. Yesterday, I listened to my colleague, Dr. Guakho, talk about stillbirths. And this is what we are using in the United Kingdom recently in a bid to minimize stillbirths and the effects of preterm births. So smoking is a big problem here. I worked in a hospital where 33% of women smoke. Fetal growth restriction, we are focusing more on preventive measures like aspirin and ensuring women have had their scans, encouraging women to report to us when there's low change in fetal movement patterns, and of course, induction of labor at around 39 weeks for higher risk women. In the intrapartum period, we are also talking about the Ctgs that Prof. Osoti presented yesterday. A Ctg, if a midwife has been taking care of a patient for 12 hours, they are not as fresh in their mind as somebody who has just come in. So what we do is a buddy system where at the top of every hour, a midwife walks out and asks the coordinator of the delivery suite or a fellow midwife or a doctor to come and look at the trace and confirm that what they are seeing is indeed correct, that the trace is normal. So otherwise, we tend to normalize abnormality. And then escalating standardized risk assessments. Now, the last one is where we can help our neonatal colleagues achieve better outcomes. So predicting risks for preterm birth at booking, and optimizing if we're able to do cervical length scans and offer progesterone if it's feasible. Screen women for urinary tract infections that can lead to preterm births. And of course, stopping smoking, considering aspirin. If indeed preterm birth comes, consider the place of birth and intrauterine transfer issues, steroids, magnesium sulfate, and antibiotics. Next slide. This is something I wanted to say called the Health Safety Investigation Branch. So anything that goes wrong in a labor ward anywhere in any corner of the United Kingdom, well, and or if a baby has a morbidity or dies, it must be reported, and then they investigate. And what they investigate is to try to come up with lessons which we can then implement to prevent future problems. So this is the current one. They are talking about early recognition of risk, safety of intrapartum care, escalation, handovers, dealing with large babies, and skin-to-skin contact, group B streptococcus, and cultural issues. Cultural issues are for like minority women, refugee women, women in distress. So you can look at that and then reflect in your own setting. How do you learn from when things go wrong? what do you do about it? Do you have a common body that then assesses health safety and passes on this back to the teams? Next slide. This is another one that is a current document called Each Baby Counts. And this slide is just showing us about failure to escalate. We are having the same problems. Failure to escalate when there's a problem, lack of awareness of deterioration and the need to escalate. Things like the soft things I was talking about, human factors, workload, errors in communication. So you can see there's the same challenges we face here are the same ones you have on the other side. Obstetrics and neonatology is the same. Next slide. This is very important, and that's why I talked about the power distance. When there's a high power distance, then as a junior doctor or as a junior nurse in the ward, as a student nurse or student midwife, I will not escalate something that concerns me. So we should empower people to be able to challenge decisions, to speak up when something concerns them, especially when it is to do with patient safety. We need to flatten the hierarchies, look at our roles as job titles, and cultures where junior staff can feel able to speak about safety concerns to senior colleagues and also to others. Next slide. In your reflections of what makes for example, the KNH labor ward unit safe, these are some of the things you can look at this paper, how to be a very safe maternity unit. And in summary, those are some of the points you need to address, looking at socio, organizational, and cultural factors, looking at training. This prompt training that I got this slide from is multi-professional training that takes care of the common emergencies and the other soft things I'm talking about. And I wonder whether there is one for the staff working in labor wards across Kenya. We can design one, or we can ask, for example, these companies that have already established packages to subsidize some for our settings. But for me, I think that in Kenya, we have all the capacity to get things done. I'm sure we can design a course or a program. We have the internet nowadays, which the rest of the world can copy from. For example, Professor Ruth Duati's research on HIV in children is quoted around the world. So good things can come from us too. Then thinking about staffing levels and feeding back to the organization, and then thinking about how we can improve our physical environment on the delivery suites to accommodate capacity and flow of patients and therefore improve safety. Next slide. I keep talking about teamwork training. And for this, I'll just say a few words that teams that train together work better together and they have fewer errors. So those update classes, those skills drills, those opportunities for teamwork training are very important. Next slide. Again, emphasizing on teamwork training. Not to repeat myself, I'll go to the last bullet. I'm just wondering whether obstetrics and gynecology trainees rotate in the NICU. I remember in Aga Khan, we did do a 3-month NICU rotation, and that helped us to appreciate how our decisions impact on the babies. And the other way around, having neonatal registrars rotating on the labor ward and providing that needed input on the labor ward will enable them appreciate what each team, what challenges they go through. Next slide. When we talk about non-technical skills, neonatology, this one I want to highlight it because in our training, we should have like sheets where the trainees are assessed. How are they developing their soft skills? Because these are what are very important at the end of the day. When you look at when mistakes happen, when you go to court, it's all about these soft skills that have gone wrong. It's really about somebody's knowledge. It's really about someone's ability to do something. It's the soft skills. So communication, team working, leadership, situational awareness and decision making, and managing stress and coping with fatigue. Those are important things. And then down there is the labor ward prioritization skills. So in our labor wards, all the patients are on a board somewhere. And you can see room 1 is the patient so-and-so, and this is their progress, and this is the concerns, and this is the next review. So at a snapshot, you can get an idea of the whole ward. So these labor ward boards, I'm not sure, it's been a while since I left, but they're important for even training and prioritization. Next slide. How do we declare emergencies? For example, on the labor ward, if a midwife is delivering a baby and there's a shoulder dystocia, or a baby has been born flat, how do they call the team? How do they call for help? Do they put their head out of the door, walk down the corridor to look for help? Do they shout? Or is there an emergency buzzer in the rooms? That's something that I found here that is quite important. A little switch that is next to a patient's bed, they can pull, and then a common buzzer goes, and everybody in the labor ward knows, and they stop what they are doing and come to that room to help. That's how we summon help. Then when we have heart attacks, we do double two through the switchboard, and you have the cardiology team and all the crash team come. What about babies when we have neonatal emergencies? Shouldn't we be doing the same when a baby is requiring more than the 5 rescue breaths? So that's something to reflect. I'm not aware whether that is in place in KNH and the other hospitals. And then who are the emergency team members? So when we go on call, we have blips, and the switchboard person has to do a test blip for everybody who is carrying an emergency response blip. That is usually commonly the registrars and above. And also the consultant will have a blip if they are on site. There will also be hematology. There will also be, which other teams? Theater, the theater coordinator is on the emergency blip thing. So anybody who might have a role in an emergency situation, they test the blips to make sure they are working on every shift. Next slide. Effective communication. Looking at the clock, yeah, we have time to carry on. Formulating clear messages and addressing them to specific individuals. I was having a chat with Lydia Okutoyi, who told me that they recently thought about ISBA. That is when you make a phone call, if you're calling that consultant at home, you introduce yourself. My name is Francis. The reason I'm calling you is, this is Francis. I'm calling you from KNH labor ward, and I'm calling A to consult, B to update you, or C, I would like you to come to hospital. So that should come out very clearly at the initial communication when you pick that phone to talk to the consultant. Then you go on to the situation. The situation is we have had a shoulder dystocia. The background is this was the mother that was in room number X that we were inducing for large for gestational age. My assessment is that we have tried all the maneuvers and they've not worked, and we are thinking of going to theater. That's not something I wish on anybody, but it's really a horrible situation. And my recommendation is that you come to hospital and join us. We would need a hand. So being very clear in the way you communicate within teams and out of teams is very important. Next slide. Next slide, please. There was a study here in the United Kingdom that looked at efficient teams. So they clearly stated the problem. They declared there was an emergency earlier. They used closed loop communication. So for example, when you call somebody, you want to find out, have they understood what you've said? So just checking whether they have understood. And then they administered treatment more quickly. There was fewer exits of the team from the room in an emergency. And I've talked about SBA. And Dr. Okutoyi told me you're using ISBA, which is even better. Next slide. Other levels of collaboration on the delivery suite, we think about shared managers. It starts at the top. Do you have administrators, for example, a common manager or common clinical director for both disciplines who can oversight? They have a bird's eye view of both events in both areas. Shared budgeting, ensuring that these places are close to one another, ensuring there are common areas for staff where they can interact and collaborate, or not just the action places. So staff rooms, rest areas, seminar rooms, all that. Next slide. And then now I will focus to your own situation at KNH. Next slide. When we think about respectful care, I would like to focus on respectful care between colleagues, respectful care with nurses, midwives, and doctors, respectful care with the person who sweeps the floor. So respectful care is not just about the patient, it's about all other people, members of the team. You'll allow me to reflect on my undergraduate experience when some of the consultants would come to harass the staff or harass the registrars. We were watching. And sometimes then after the consultant leaves, the same registrar who was harassed is left with the patient to take care of. Will the patient take that registrar seriously? So looking at bedside manners by colleagues, seniors, those who are at their peers, because I am aware of the high power distance, can challenge behavior. If your peer, who is a senior, is misbehaving, I call it misbehaving, by the bedside, they're not being a good role model, then call them aside and tell them, hey, we have to be a good example. Treating even the junior most student as a colleague is very important. There are a lot of studies that I saw that have been published on respectful maternity care and have been cited, and most of them are from Kenya. Next slide. When we look at staffing norms, staffing is always a big issue. Unfortunately, I don't have a magic bullet because there's no evidence-based norms for staffing of maternity units, and therefore it's very difficult to tell you what is the benchmark and the standards. But this just calls on the managers to think ahead and look at the workload and look at the timetables, look at the contracted hours. If you've contracted doctors or consultants who are supposed to be on the labor unit or on the NICU and they're not there for the times they are contracted, then you need to crack the whip. And if they do not follow suit, then you need to ask them to leave to give the opportunity to another doctor who is willing to offer the service. So it's just that there's no hard ways about it. We just have to crack the whip. And then at each handover, we have to consult with one another in NICU and obstetrics about staffing status. Next slide. Thinking about risk and effective risk communication, I just wanted to caution us, the obstetricians, because a lot of times in antenatal clinic, the way our system is that we identify low-risk mothers and then we identify high-risk mothers. We tend to over-concentrate on the high risk and forget the low risk. The funny thing, a lot of times, complications they occur in the women that we classified as low risk. So I'm just trying to caution us that we must remain on our alert that the initial classification we give a mother does not stay on. Obstetrics is very dynamic. And it's not until I came out here that I started viewing obstetrics as a very different specialty. It is indeed an acute specialty. So if the administrators at the top level do not view obstetrics and neonatology as acute specialties, they need to be aware of that and they need to look at them differently from other specialties and support accordingly. So being aware of those limitations of how we classify patients is important. And then on the right-hand side, how we communicate risk to the patients. If we have, for example, a mom at 24 weeks with PPROM needing input from an obstetrician, input from a neonatologist, there are hard decisions to be made. How do you deliver this baby? When do you deliver the baby? What are the possible outcomes? What are the costs of taking care of this baby in NICU? What are the long-term things if the baby becomes disabled? So those are opportunities for collaborative working. Next slide. I think if we stay in one silo, obstetrics in their silo and NICU on their silo, and neonatal team on their silo, then we are not aware of the challenges that we are facing. So we must communicate a lot more and spend time in one another space so that we can then appreciate how our individual decisions affect outcome. Next slide. There's the issue of minimizing our unwarranted variations in care. My experience, I hope it has changed, was a situation where consultant A would say that we are going to manage the patient this way. In the afternoon, consultant B comes and says, no, that other consultant was wrong, we are going to manage this way. And there's a bit of conflict. First, that is not good for training of residents, because they end up with conflicted opinions. So I would like us to move away from opinion-based practice to evidence-based practice. And this is where teams sit down and come up with collaborative guidelines for how they manage their care. And irrespective of whether Francis read a fantastic paper last night and I want to manage a patient in a particular way, and it's not in the guideline, then I should be stopped, because our guideline says ABCD. And then what I should do is engage my clinical director, and at the next meeting, we discuss this new evidence and see whether we revise our guideline. So we need standardization of protocols, guidelines, pathways, and we need to be auditing these things so to make sure that we are in sync. We can avail them on mobile apps. I know Professor Wanyoro is quite good with mobile technology. That was the subject of his PhD. And so he can guide us on how we can have guidelines on mobile apps for easy accessibility. Kenya is leading in mobile technology. That's why I'm belaboring this point. On the right-hand side is collaborative clinical and research networks, which are opportunities for collaborative working again, developing a guideline that can be followed by those people who feed the morbidity and mortalities to us, who are out there that we wonder how to engage with them. If they have a guideline, you'll be surprised even that provider who is not following, who is somewhere deep in a slum we cannot access, and they're taking care of a mother. In the interest of the mother, let's have a guideline somewhere they can log in and download and at least try to follow what's supposed to be done. Next slide. I borrow from the, in England, we have 17 academic health science networks. So what I'm trying to say is, like, for example, KNH with the surrounding universities, the surrounding industry players, and patient interest groups. I know there's a group called, like, for twins or moms who have lost their babies, charities and the public, all coming together in a network to contribute to care and approaching rich Kenyans so that when they die, their wealth doesn't end up in the courts. So we tell them that they can leave the wealth to the hospital to do some philanthropic work with it. So all that would be the work of such networks. Next slide. Now, when things go wrong, what should we do? We should do something called professional duty of candor, and we should have no blame and no shame culture between teams and within teams. I will belabor this point of appreciative inquiry, first starting with what the people have done well before telling them what they did not do. We should have a system both in neonatology and obstetrics where we capture incidences. And these are not just clinical, all sorts of incidences which we can learn from, with the aim of safeguarding the patients from further harm and preventing repeat harm. We learn from imperfections. Next slide. I went to a little bit more depth with professional duty of candor. This is about openness and honesty with patients when something goes wrong. We need to tell the patient exactly what has gone wrong. For example, I was in theater doing a forceps delivery, and I ended up with a buttonhole injury. That means it's a hole going from the vagina to the backside. And I had to tell, to apologize there and then, because the patient was under a spinal. I told them, I'm very sorry, the complication I had spoken to you about when we did the consent, unfortunately has happened. And I informed the anesthetist and asked the anesthetist, this is what I want you to do. And I escalated it to, I called for help. So telling the patient at the soonest possible, apologizing to the patient, offering a remedy of support and remedy, and then explaining to them what are the implications, short-term and long-term. This is how to avoid being sued, because if a patient then discovers you are hiding something, then later you'll be in hot soup. And it's also good to learn from these things. And then the honesty and openness also goes to colleagues, our employers, our organizations, as well as our regulators. The last point is, for example, you are aware of a colleague whose practice is endangering patient safety. You are required to inform the regulator in anonymous fashion, raise a concern, then they can investigate this colleague and find out what is wrong in the interest of patient safety. Patient safety comes first, and then the next thing is your colleagues, the team, and then the last thing is yourself. Next slide. In the neonatal unit, some suggestions. If we have a blood gas machine that can process blood using capillaries, that would be helpful. And the same blood gas machine can be used by obstetrics for assessment of cord blood gas analysis, which gives us more information about babies that we need are at risk, we think that are at risk. And also when we think moms have sepsis and we need to assess their lactate levels, we can use the same machine. I'm aware that at the minute we have syringe samples, which are causing a lot of trauma to the babies. We get femoral samples and radio samples when we can do something better. There's a lot of money in the system looking at how much has been said to be lost every day in corruption. So that can be put at a better use if we make the managers aware that these things are necessary. But if we keep quiet, then they will find another alternative use for the money. Next slide. A transcutaneous bilirubinometer, this would minimize the rate of exchange transfusions. Blood is very expensive. And if you think of the staff and all the processes that go into a blood transfusion, just having that bilirubinometer will make a lot of change. Again, something to ask the authorities to purchase urgently. Next slide. The preterms, this is for us in obstetrics as well as NICU, ensuring that there's a resident attending deliveries before 34 weeks, ensuring that we are using a plastic bag to receive babies below 32 weeks to conserve heat before they go to a neonatal unit. Delayed cord clamping, this is for us obstetricians. The first minute, that will help a lot. If surfactant is expensive, but we can use something called Ensure, intubation, then you give surfactant, then you extubate onto NCPAP due to scarcity of ventilatory machines. Or we can tell the machine, the system, we need ventilatory machines. Let's not, I heard of somebody saying poor medicine for that world. No, no, no. We have a lot of money in our system. We just need to ask for it. And then the last one is for us, the obstetricians, steroids. So first of all, it's recognizing preterm labor, steroid administration, magnesium sulfate, antibiotics, and consulting with our colleagues. Next slide. Now I have 4 minutes to go. I'm participating in quality improvement projects and rewarding good clinical practice and supporting those who depart from expected practice as per standardized guidelines and protocols. For both units, that's very important in the interest of patient safety. Next slide. This is important. In obstetrics, we have lists of situations where we must escalate to a senior registrar or a consultant, and situations where the consultant has no choice. They have to come when I call them to come, or when another consultant calls them to come. Next slide. That is just an example. If you look on top, there's situations when the consultant may attend if they have assessed the doctor on the ground and they are happy with their competencies. If we are trying an instrumental delivery in theater, cesarean section at full dilatation, cesarean section in women with a high BMI, preterm sections before 32 weeks, and confirmation of preterm death. So if you have a senior registrar who can do that, that's fine. But the ones down there, eclampsia, maternal death, intrapartum stillbirth, a cesarean section for placenta previa, PPH more than 1.5 liters, return to theater, multiple complex cases, vaginal delivery of the twins, BMI more than 50, sections below 28 weeks. And whenever they have been asked to attend by a doctor or by the delivery suite coordinator, they must come. Then the last one is situations when the consultant must be told that there's a second stage for vaginal twin birth or there's a vaginal breech birth. So we need to come up with, I'm not saying you copy this one, but you need to look at your situation. And there's no two ways about it. It just has to happen. You look at obstetrics, you look at neonatology and tell the consultants, these are the situations when you must come. I'm aware of the workload issues, but then it's upon us to become more innovative and ask the administration to fund resident consultant jobs who are on shift 24/7 to turn around the service, as well as consultant presence on the labor ward and the neonatal unit. if you think of the complications and long-term issues when a baby has had a disability, just having senior input saves a lot of money and distress and saves lives. Next slide. Important equipment to have resuscitation trolleys in neonatal unit and labor ward, and they should be checked every morning and during handovers. And also how we transfer the babies from the labor ward to the NICU. We need a transport incubator and resuscitators. So there is no two way about it. We need to change outcomes. We need to invest in these things. Next slide. These are just some resources. You can look at the slides later. Next slide. Next slide, please. I'm keen to finish on the 50th mark. So about collaborative working, we need mutual humility and be prepared to learn from one another. It's not about a certain group of people. We need everybody to buy into it. Communication is key. Developing mutual values, aims, and aspirations is important. Honesty and openness. I have tried to be as open and honest with you as possible. Agenda and setting strategies. Next slide. And then a collaborative and intraprofessional team supports high quality and safe care, supports patient and staff satisfaction and engagement, and it supports the organizational efficiency and innovation. Next slide. I acknowledge my colleagues again that I consulted and whose thoughts have been incorporated in this talk. Next slide. And on the 50th minute, as scheduled, I finished the talk. Asanteni sana.
Thank you very much, Francis. That was very, very interesting. We're hoping for a future when all of that can happen. As mentioned before, we'll keep our questions. There's a session for discussion, and kindly, so that everyone, at least some people, can get to contribute, put on the chat group. We can be answering some, the presenters will be answering some of the questions as the presentations continue. I'd like to introduce the next presenter. Our next presenter is Dr. Anne-Marie. She is going to be talking on communicable disease and perinatal health. Dr. Anne-Marie is a consultant pediatrician at the University of Nairobi, unit of clinical infectious disease, and she specialized in pediatric communicable disease. Anne-Marie Macharia, karibu sana.
Thank you very much, Dr. Witty. I'm trying to share my slides. I don't know if they're visible.
Yes, I can see communicable disease and perinatal health on the screen.
Okay, thank you. Good afternoon, everybody. I'd like to thank the organizers for giving me this opportunity to make this presentation. And I'd especially like to recognize Professor Ndwati, who has been an excellent mentor to me. She's actually the reason I ended up in the Infectious Diseases Fellowship. And to borrow from Dr. Gidai, she's one of our teachers with whom there's a very short power distance. She's been extremely approachable. I know she has mentored so many of us, and I think she is open to the most junior person. And even more so during this COVID period, I've appreciated her availability, much as she has not been able to be with us in the hospital. So I'll get into my presentation. I will be talking about communicable diseases and perinatal health. This is a very broad topic, so I will, this is the outline of it. I'm just going to go through the epidemiology, and then we'll look at some important neonatal infection syndromes, a word on maternal vaccines, and then I will summarize. So in 2019, according to the UNICEF data, Kenya's neonatal mortality rate stood at about 19.6 per 1,000 live births. And in that chart there, you can see that the contribution to this neonatal mortality from neonatal sepsis was about 16%, that teal colored block there. But infections tend to account for a lot more of the mortalities, because even amongst diagnoses like preterm birth complications, pneumonia, and other unclassified conditions, many of these babies tend to have sepsis or other infections that are actually contributing to their morbidity and mortality. So I've just looked at these syndromes according to their etiology, and we'll touch on a few of those that I have highlighted. So for example, there is congenital syphilis. Chlamydia also causes infections in the newborn, tuberculosis, and group B strep. Amongst the viral, HIV remains a very important cause of perinatal infections. And then we have hepatitis B and C. I've put the torches there, though toxo is a parasitic infection, but looking at the rubella, the cytomegalovirus, the herpes viruses, and Zika, and amongst the parasitic infections, malaria. So I've highlighted this even though I won't be able to go into all of them just due to time constraints, but perhaps I'll add a word at the end. So we'll just get straight into perinatal HIV. So this is the current situation in Kenya. This is 2019 data. And our national prevalence stood at 4.5%, with about 1.5 million persons living with HIV of all ages, all the way from 0 into the adulthood. You can see that prevalence was higher in women at about 5.7% compared to 3.1% in men. Like I said, we have about a total of 1.5 adults living with HIV. Those are the over 15s. So about 10% of the 1.5 persons living with HIV are children aged between 0 and 14 years. If we look at the new infections in the year 2019, we had about 41,416 infections in all ages. Majority of these were in adults, but we also had about 6,800 infections occurring in children, and many of these are in the age group that is of interest today, the perinatal age. One thing that is of concern is the large number of new infections amongst our adolescents and young people. For those of us who attended the perinatal seminar, the series that we had a few weeks back, it stood out just how vulnerable our adolescents and young people are, particularly in this COVID season. And the HIV data, and this is prior to the 2020 COVID era, 61% of our new infections occurring amongst adults were in the adolescent and young people aged between 15 to 19, and majority of these were actually in women. So if we look at our Mtct trends, this chart is showing what our rates of mother-to-child transmission of HIV have been between 2012 and 2019. And you can see the curve had sort of taken a downward trend towards 2015, 2016, when it was at about 8.3%, but we seem to be going back up. In 2019, the national Mtct rate was about 10.8, and our target is actually less than 5%. Yeah, we're aiming to eliminate all transmission of mother-to-child, mother-to-child transmission of HIV. So we've noted that gradual increase over the past 4 years in the Mtct rates. And like I said, adolescents and young girls are becoming a subpopulation of interest as we have increased teenage pregnancies. This is shown very dramatically in this map of the country that is showing where did the new HIV infections occur and where were the teenage pregnancies occurring. And we can see that most of the new HIV infections and teenage pregnancies were high in the same geographic locations. So if we go to the map, we can see the areas in yellow and red are the areas where we had high number of new HIV infections, those areas there. And looking at the number of teenage pregnancies, the purple dots, we can see they're distributed amongst the same areas. So here in the western part of the country, into Nairobi, a bit into the central region of the country, and then down at the coast. So about 3,000 teenage pregnancies were reported amongst young girls aged 10 to 19 in 2019. And this is a figure that we will need to be watching in subsequent years because we're already seeing many young girls coming into the pediatric ward with young babies who have sepsis. And I'm sure the experience is the same for our obstetrician and gynecology colleagues. And we had talked about the higher rate of sexual activity amongst our young girls, whether it is transactional, whether it is occurring in the setting of gender-based violence during this period. It was also noted that HIV prevalence was high amongst the women who had an earlier sexual debut. It was 12.5% amongst those who had their sexual debut before 15 years, compared to just 4.7% amongst those who started having sex after the age of 25 years. And we'll see what the implications of these are in terms of reducing our MTCT rates. This is a snapshot from the NASCOP early infant diagnosis chart that looks at the number of new infections. So in 2019, there were a total of 6,809 new HIV infections. We said the MTCT rate was about 10.8%. And then it's actually shown per county. So we can see again, as expected, perhaps in the high burden counties, a larger number of babies who were actually HIV infected during that perinatal period. This graph is looking at what is our target and performance in terms of women having that first ANC visit, having HIV screening done, and having and being tested for syphilis. So the pink bars show the estimated number of pregnancies. The years are down here all the way from 2016 to 2020. And then the green line there shows the number of women who had at least one ANC visit. And then the purple line is looking at the HIV coverage, which in some years was a bit dismal. Like we can see in 2019, there was a massive dip and only about 69% of women who needed to have been tested were tested. Went back a bit in 2020, and the testing for syphilis is even poorer. Yeah, and the target for all of these is actually 95%. So we can see where we are falling short in ensuring mothers are coming to the clinic and they are being tested for HIV, they are being tested for syphilis. So let us remind ourselves about the timing of HIV infant infection. During pregnancy, if you're just to take the total number of infected children, about 20% of them would have acquired their HIV infection during pregnancy, 40% during the delivery and peripartum period, and 40% of them post-delivery through breastfeeding. So without intervention, out of 100 children, we can see at which time points they would have acquired the HIV infection. This graph is just borrowed from work done by Dr. De Kock of CDC, and it was looking at the absolute risk of transmission, both amongst women who are breastfeeding and those who are breastfeeding for 6 months and breastfeeding up to 18 to 24 months. And we know for us as a nation, we insist on exclusive breastfeeding for at least the first 6 months of life, because it has been found to be important for infant survival, with much higher rates of infant deaths among those who do not breastfeed, up to 8 times compared to those who are breastfed, independent of their HIV risk. So we can see that the overall MTCT rate during breastfeeding, for those breastfeeding for a shorter period, is a bit lower at 5 to 10%. And then if there's an extended period of breastfeeding, then it can go up to even 20%. And overall, if we look at all the transmission during pregnancy, during delivery, during breastfeeding, the overall MTCT rate, if the child is not breastfed, is about 15 to 30%. If they're breastfed up to 6 months, between 25 and 35%. And for those breastfeeding up to 18 to 24 months, up to 30 to 45%. So there are those children who will remain uninfected despite no intervention. However, once the mother is put on combined ART and they're virologically suppressed, the risk of transmission falls to less than 1%. So we cannot overemphasize the importance of having all our mothers tested and started on ART. We'll again just revise the factors that increase the risk of transmission of HIV to the infant. And these include maternal disease, including high plasma viral load. Again, we are thinking of when is this mother acquiring infection, because we know in acute HIV disease, there is that initial rapid replication with a very high viral load, a low CD4 count, and also rapidly progressive illness in the mother. Of course, failure to take ARVs for treatment or prevention at any stage will increase the risk of transmission. And even if they're being taken suboptimally, if there is no viral suppression, if the mother is on a regimen to which is already resistant, then again, the baby is at risk of acquiring HIV. Specific to the pregnancy period, factors like low vitamin A have been cited, although this may also be related to the severity of HIV disease, maternal anemia, placental infections, so chorioamnionitis, presence of STIs, having multiple sexual partners. During delivery, if there is increased genital shedding, and again, this is increased when there is a high viral load or ulcerative STIs, delivery should usually be vaginal delivery, except if there is a very high maternal viral load, in which case sometimes cesarean section is an option. We should minimize invasive procedures. Prolonged rupture of membranes becomes a risk factor for both HIV and sepsis, and the first twin is at higher risk of acquiring infection. We always want to encourage exclusive breastfeeding. Breastfeeding of any duration poses a risk to the infant, but like we have said, if mom is virologically suppressed, that risk is minimal. So we want to avoid mixed feeding, particularly in those first 6 months of life. We want to look at, is there HIV in the breast milk? So mom needs to be virologically suppressed. We want to ensure that we have addressed any breast disease. Looking at that mom's latching, how is the baby attaching to the breast, are the nipples cracked, does she have mastitis? And when we get moms who have had some failure of lactation, and then they come into the ward with a baby who has sepsis, and we're trying, for example, to reestablish lactation, that is also a period of increased risk. And we'll see that that should be addressed through having mom on treatment and also having the baby on infant prophylaxis. So we're going to just briefly go through the 4 prongs of PMTCT. I know we're all familiar with these, but because sometimes we fail to practice them, I think it's good for us to have a revision. So the first prong is primary prevention of HIV, especially in our young women. If we're not able to prevent HIV in the young women, we should be able to prevent unintended pregnancies amongst those who are HIV infected. And amongst HIV-infected women, we should be able to prevent transmission of HIV from the infected mother to her infant. And if the infant does get infected, provide support to the mother and her family. So we'll look at the first prong, which is primary prevention of HIV. I just had some thoughts around this, and there has been a lot of studies done. And things we can do are, for example, to promote abstinence and delay sexual debut. We saw the risk of new infections was much higher in those girls who were starting their sexual debut at a younger age compared to those who started at over 25. And then there is this concept of secondary virginity. One of the speakers who was talking from one of the counties when we had the perinatal symposium was talking about a group of social workers, teachers, a team he has put together to talk to the young mothers who have gotten pregnant, the teenagers who are pregnant. Because, you know, once the girl has a baby, the likelihood of her continuing to be sexually active and continuing to have more children is much higher than that girl who has not. And so promoting that concept of secondary virginity, we should be providing appropriate sexual and reproductive health education. We've talked about screening for STIs, particularly ulcerative ones like syphilis that increase the risk of infection. And then there is this issue of addressing sexual health in pregnancy. You see, that pregnant mother continues to be sexually active. So maybe because we're not addressing things to do with family planning at that point, sometimes we forget to discuss with her safe sexual practices. And yet we've seen a number of women whose babies go on to acquire HIV, themselves acquire infection either during pregnancy or in that peripartum period. So we should be able to advise them on barrier methods, including condom use, use of vaginal rings, especially when they have other risk factors, for example, multiple partners. Sorry, there's quite a bit of interference. Is that coming from me? Okay.
Dr. Proceed on our end, you're quite clear.
Okay, thank you. So yes, advising them on barrier methods such as condom use. And then we said that testing should occur not only at that first ANC contact, it should also happen in the 3rd trimester, at labor, at delivery, at 6-week visit when she brings in the baby for the first round of vaccinations, and every 6 months thereafter until complete cessation of breastfeeding. Dr. Carey, our own John Carey, and others have done studies looking at the how well mothers accept that second testing, because I think majority of them do get that first test. It is the subsequent HIV testing where we are not doing as well. And they found that older mothers, most women were willing to accept it, but more of the older mothers were willing to be retested when they had already been tested once during pregnancy. And then one of the pediatric residents, Dr. Mola, looked at the uptake of repeat testing during pregnancy, labor, and the postnatal period after an initial pregnancy test in Kisumu. And she found that in Kisumu County, we were not doing very well. I think less than 50% of women were actually getting offered that second HIV test. So it's a place where we need to put a bit more effort. So looking at the second and third prongs, preventing of unintended pregnancies, there is an unmet need for family planning, recognizing that children are becoming sexually active earlier. So as we even advise on abstinence, making sure that young girls who do not intend to get pregnant are able to prevent pregnancy. And then in prevention of vertical transmission, there's that target that we have been set by UN AIDS, 95, 95, 95 by the year 2030. This means that 95% of the HIV infected women must be identified, and at least 95% of them should be on treatment. And of those on treatment, we should be aiming for 95% virologic suppression. We know that there are very many challenges with this new test and treat strategy. Yeah, so there is really no option for opting out. When a woman comes into the ANC and is tested positive, she's supposed to be counseled and ideally started on treatment on the same day. And in case she does not come back, she's also supposed to receive drugs for her infant prophylaxis. So several bottles of nevirapine, several bottles of AZT to take home with her. I'm sure you'll agree with me, it's a lot, you know, to come in, receive this diagnosis, be immediately started on treatment, and somebody is already discussing with you the implications for the newborn. So there needs to be a lot of adherence support, even as, yes, we need to start all these women on treatment, because if we don't, they may not come back to the health center, but we need to be really able to support them. Make sure they come back for subsequent visits. Do contact tracing when they have been lost to follow up, and keep on testing them, because during pregnancy, you want to do your viral load testing a lot earlier. As soon as she's been started on treatment, you want to do a viral load at 3 months as opposed to the usual 6 months, and make sure she's virologically suppressed as soon as possible. So there needs to be that increased uptake and adherence. We talked about the risk factors around delivery, so making sure that skilled delivery is available and promoting exclusive breastfeeding in the first 6 months, which I will not belabor because I believe we are talking about nutrition and breastfeeding tomorrow. So how should maternal monitoring be done? Yes, I already said the newly diagnosed mother should have testing 3 months after she's been initiated on treatment, and she should actually receive testing 6 months, every 6 months until cessation of breastfeeding. For those who are already on treatment, you need to get a current viral load. It doesn't matter when her last viral load was done. As soon as you realize that she is pregnant, you need to get her current viral load, ensure that it is undetectable. And if it is undetectable, then you can continue with the 6-month testing as above. However, if her viral load is detectable, so it is greater than undetectable, I think there's an error there, you need to do adherence assessment on a monthly basis. And if it remains greater than a detectable level with our cutoff of about 1,000 or even that low viremia, then you can discuss changing her to a more effective regimen and have discussions within your multidisciplinary team to see the most appropriate regimen to put this mother on. With the advent of the optimization of treatment, we now have dolutegravir, which though earlier studies had shown increased risk of neural tube defects, we now know that it is safe to give to women. So you do give them the option, you do counsel them, but drugs like the integrase strand transfer inhibitors and the PIs will also bring down that mother's viral load very quickly. So when you get that woman whose viral load has remained high and she has been on treatment, you need to intervene very quickly. So assess her barriers, find out if her partner has been tested, find out whether it is adverse effects she is having, and ensure that she's comfortably able to take her ART.
Dr. We're running out of time. Are we almost through?
No, we are not. I had been given a bit of extra time by Professor Ndwati and Dr. Kihara. I think one of the speakers they said was not going to do a presentation.
Okay.
I'm just about halfway, yeah? But
Well,
I'll try.
maybe we give you, would you be able to do in another 10 minutes then?
Let me do my best.
Okay, thank you. Sorry about that.
HIV is the main one. It's okay. So infant prophylaxis. So we said the prophylaxis should be provided to the mother at birth. We do dual prophylaxis until 6 weeks when we stop the AZT, and nevirapine is then continued until complete cessation of breastfeeding. Then the baby should be tested at birth or within 2 weeks of delivery, at 6 months and 12 months using a PCR test. And then antibody testing will be carried out at 18 months and every 6 months during breastfeeding. And the last test is done 6 weeks after complete cessation of breastfeeding. So we've been having challenges in testing because of stockouts of our PCR kits. And we also need to think about nevirapine is our main drug for pediatric prophylaxis. And now that it is being phased out for adult treatment, are we going to continue to receive stocks? Should we be thinking about manufacturing this in country? So I'll now move to other sexually transmitted infections, particularly ulcerated. And the two main ones that I'll be discussing are herpes simplex type 2 and syphilis. And note that an individual may have more than one, and both herpes simplex and syphilis may be transmitted from the mother to the child. So looking at herpes simplex infection, it presents as vesicles that progress to painful ulceration, and they may occur anywhere in the genital area. And shedding may occur even in the absence of active clinical disease in the mother. So patients with active disease should be counseled to, one, abstain from sex. And if they're having an active episode during delivery, you can discuss perhaps doing a cesarean delivery. So this is how perinatal HSV infection looks. It's usually some bullous lesions, some vesicles, clusters of vesicles with an erythematous base. Sorry, I did not get it on a darker skinned child. And there are three main presentations. You may have disease that is localized just to the skin, eyes, and mouth, but more commonly in that neonate whose immune system is still very immature, they tend to have CNS disease presenting with meningitis and other non-specific signs amongst their seizures, or with disseminated disease. And this is managed using intravenous acyclovir. Syphilis is caused by a spirochete called Treponema pallidum, and amongst women, it will cause early, it may cause spontaneous abortions or stillbirths or even perinatal deaths. So when syphilis is syphilis can be transmitted to the unborn baby at any stage, and it's about 60 to 100% during primary and secondary syphilis. So this is how it presents. The placenta is often large, pale, and the cord is described as looking edematous. The baby may present with jaundice, hepatosplenomegaly, a nasal discharge that is just sort of snuffles, you know, a clear rhinitis. There's a generalized rash, and what is classic about it, you can see it's usually also on the palms and soles, so it can be on any part of the body. The baby will have lymphadenopathy, skeletal abnormalities that may also present as a pseudoparalysis. And the lab tests, apart from being able to do your fluorescent treponemal antibody, other things you may find elevated at your transaminases, a delayed prothrombin time. And if you're able to do a microbiological diagnosis, you may visualize the spirochetes on liver biopsy. And there are those radiological abnormalities that have been put there. So a presumptive diagnosis is based on a positive treponemal antibody test in the mother, and the individual should be treated immediately. We screen her. We saw we're not doing very well in terms of screening. We should screen more mothers and ensure they are treated. And the antibody test does not immediately revert to negative. That should be noted. And penicillin G is the treatment of choice, even for congenital syphilis. Dr. Kihara particularly wanted me to speak about perinatal tuberculosis. I think this is the last one that I will just focus on for maybe 6 minutes or so. Kenya is one of 30 high burden countries. We have even cases of MDR-TB. In 2019, we had 86,504 new cases, and 10% of these were in children. Our most recent TB survey was carried out in 2016. Prior to this, I think it had been done in the 1950s, and we just used to rely on program data. And what was shocking or surprising, the surprising finding in this survey was that our TB prevalence rate was much higher than we thought. You know, we'd classify ourselves at about 300 per 100,000, but our actual TB prevalence is 558 per 100,000. In males, it's as high as 809 per 100,000. And this translated to a prevalence to case notification ratio of 3.5 to 1, meaning that we were missing 40% of our TB cases. What also surprised me when we looked at this, and it's something that we discussed within the ID fellowship, is that we need to also challenge what are we using as screening for TB, that traditional asking for cough of duration of 2 weeks, because only 57% of those found to have TB reported cough of any duration, and only 9% of them had a cough that had lasted longer than 2 weeks. 43% of cases actually had no cough. Surprisingly, other things like chest pain, fever, night sweats, weight loss, fatigue, and shortness of breath were more common, and 88% of those found to have TB had an abdominal chest X-ray. So this means that we need to be rethinking when we're doing TB screening within our HIV clinics, within our antenatal clinics, are we really taking a very good history? So congenital TB happens via hematogenous spread through the umbilical vessels or aspiration or ingestion of infected amniotic fluid. If the mother has extrapulmonary tuberculosis, miliary TB, then there is higher risk of transmission. It may also occur after birth, and this is then classified as neonatal TB. It has a high mortality, and because of the immature immune system, it's usually disseminated. So how do you diagnose it? You must have appropriate maternal screening, as we have discussed. Sometimes things that give you a clue are history of recurrent abortion, stillbirth, preterm labor, or a woman who is HIV infected. Then your index of suspicion is high. It may present with fetal intrauterine growth retardation or low birth weight babies. Examine the placenta for tubercles. That may be your first clue. And then babies will present between 1 and 84 days with a median age of presentation of 24 days. But symptoms are non-specific. It is like any other sepsis. They have poor feeding, fever, irritability, they're not thriving, they have cough, they have respiratory distress. Almost 100% of these neonates will have hepatosplenomegaly. A large proportion will have lymphadenopathy, and then other non-specific signs and symptoms, as we have discussed, including DIC, osteomyelitis, or paravertebral abscess. So you need a high index of suspicion if there is poor response to antibiotics, an atypical pneumonia, and most importantly, history of contact. So diagnosis is made through gastric aspirates, induced sputum, tracheal aspirates, ascitic fluid. So get any fluid or any microbiological specimen and send it for microscopy, send it for gene experts, send it for culture. And how do you manage them? If the child is then screened and found not to have TB, the baby we've described in all likelihood has TB. But if you just have a mother who has history of TB, but when you screen the baby does not have active TB infection, you need to treat them, because untreated, they will develop latent tuberculosis and later on develop that disseminated picture. So the management is isoniazid prophylaxis given for 6 months. Mantoux test is used in some countries like South Africa to guide the duration of therapy. And then they do a BCG 2 weeks after they complete the IPT to guide whether or not they will then give their BCG. They do the Mantoux, and then if it is negative, they give the BCG. But for us, give the isoniazid and then administer the BCG vaccine 2 weeks after completion of the IPT. And note that breastfeeding is not contraindicated. The mother should mask. At least now we are not having stigma about wearing masks. So she should have an N95 mask. She should be on treatment. She should continue to breastfeed her infant. A short word about group B Strep, which is a leading cause of neonatal mortality. It causes 2 pictures of neonatal sepsis, an early onset that is primarily respiratory symptoms, and a late onset type that is more meningitis and CNS symptoms. So we do have local data. As far back as 2003, Dr. Laving and others had looked at babies who presented with sepsis to see how many of them had neonatal meningitis, and they found the prevalence of meningitis to be 17.9% in those with sepsis. The organisms they identified as causing this were E. coli, leading at 46%, and group B strep at 27%, and others. More recently, Dr. Osoti, who made a presentation yesterday, looked at GBS in women at Kenyatta. And 20% of women enrolled tested positive for group B strep. And this screening was being done at a mean gestational age of about 35 weeks. Interestingly, all 10 serotypes of GBS were identified in these women, and about 70% of them were colonized by more than one serotype. Typically, you'd expect GBS to be sensitive to penicillin, but we had penicillin resistance in 74%, ampicillin resistance in 55%, clindamycin resistant in 30% of isolates in this particular cohort. So we need to be rethinking, do we need to screen women for GBS? If we have not screened them and they come in at risk, do we want to just go ahead and give the antibiotic prophylaxis, because we do get a lot of babies coming in with sepsis. So way forward, now that people have started, vaccines have become topical because of COVID. Already we have maternal immunization. It is only directed at this point. We get a Tdap. Tetanus infections have really gone down. I think I last saw a case many years ago, and then I cannot compare to what we used to see in my undergraduate days. So vaccination is important. Influenza vaccination. These vaccines are at advanced stages of development: Group B Strep vaccination and respiratory syncytial virus vaccination, which tend to cause bronchiolitis in newborns between 0 to 3 months, together with all the other things that we have talked about. So in summary, I will echo Dr. Githai again. We need close collaboration between our obstetrician and pediatric teams for optimal neonatal outcome. We need to address the challenges that we have identified in preventing these perinatal infections. As a country, we have very clear policies regarding our TB, HIV, syphilis, but we need to follow these. And we need, I think, to develop a policy around Group B Strep screening. And that is the end of my presentation, and I think we'll have questions thereafter. Thank you very much.
Thank you very much, Dr. Anne-Marie. I could have listened to you the whole day. It was so interesting. I was wondering whether you're giving a talk on perinatal health or it was an obstetric course. I really love the talk on HIV. However, we don't have time, so I'd like to welcome Dr. Githai to give his second presentation on non-communicable diseases. Unfortunately, we've eaten up a bit of time, so I'd request if Dr. Githai, just beg your indulgence, if we could do it in 15 minutes. Thank you.
Thank you very much. I am usually a very fast speaker, so I will spend less than 15 minutes. Now, in terms of, thank you very much, Anne-Marie, as well. I found your talk very refreshing because over here, we don't deal with the infectious conditions. They go to a different department unless it's just the intrapartum bit. Thank you. Next slide. That's what you've seen before. Next slide. So when I was asked to speak about non-communicable conditions and perinatal outcomes, these are the questions that I asked myself. What are they and why are they important? And because there are very many, I thought what I would do is just give us a general considerations kind of approach and how to approach these conditions by phase of pregnancy, and then point you to some resources. Next slide. So I thought of them in a systematic way. For example, cardiovascular, the one that I would point out is heart disease. What I will say is that the same way we say that in a pregnant woman with pelvic pain, it is an ectopic until proven otherwise. In the same way, if a pregnant woman comes to you and they have chest pain, then we should do cardiac troponins and an ECG. The other things that happen is breathlessness, which are very common with pregnancy itself and anemia. Some of them are actually having a cardiac event. Next is obesity, which is a big issue. Over here, I didn't have time to look at studies in the setting and what kind of BMI ranges. Next one is thromboembolism. Venous thromboembolism can happen across first trimester when you have hyperemesis gravidarum. You can have it in any phase of pregnancy up to the puerperium. We had a talk recently, which I gave through COGS on VTE, so I'll not spend much time. So thromboembolism, what did I want to say? Just risk assessment for patients antenatally and in the wards helps a lot. Respiratory, I'm thinking about asthma. So ensuring patients have at least the Ventolin inhaler and they are available as part of our emergency box. Endocrine, the most common one we deal with is diabetes, but there are others. Connective tissue disorders, we have things like, even chronic fatigue syndrome, things like SLE. Neurology, we have stroke, management of our blood pressures, and the occasional time we meet an aneurysm. Renal, most patients with renal problems will have problems conceiving, but some do conceive, but we do manage patients who are post-transplant. Then we have liver issues, gastrointestinal, the common ones we see is Crohn's and ulcerative colitis. Skin, there are a lot of skin issues, but you may have patients with the chronic ones that are not the common ones in pregnancy. Hematological, I thought of sickle cell disease being common in your area and also here, and then patients who might have cancer. That is not exhaustive, but those are the common things that I thought of. Next slide. And why are they important? If you look at the Kenya Confidential Inquiry into maternal deaths 2017, you find a listing of those conditions that can, although most of them are infectious, but they do contribute to indirect causes of maternal death. And on the right, for the case of the United Kingdom, our latest maternal death inquiry showed that heart disease and chest pain were more common, and they are commoner in women who are obese, smokers, and have diabetes, and we are being pointed towards breathlessness at rest as being abnormal, and therefore those patients should be investigated. Next slide. In the neonatal side, when we think of medical conditions or non-communicable diseases in pregnancy, then they contribute to preterm births because either from the condition itself or from ourselves as obstetricians intervening, they do contribute to fetal anomalies. What comes to mind is things like diabetes, epilepsy, all those can contribute. And babies will usually have intrauterine growth restriction with some of them, and some may unfortunately die. And those that thrive, those that survive may not thrive because they have long-term health and disability issues. Next slide. So you remember that we classify maternal deaths into direct and indirect maternal deaths. And I think this classification should be discarded because it only came to us in 1975, and its original intention was to focus interventions and provide insight into indirect causes. However, what has happened is people in low and middle income country settings have this, it was put in our system when we were training that we focus on the direct maternal deaths. Those are the biggest issue. And then these others, it's only now that we are talking about them. So this binary approach and thinking needs to stop. We should treat all causes of maternal deaths as equal, and they should all be addressed concurrently. Next slide. The key concerns is that they may be pre-existing or new onset. And obviously nowadays women are delaying pregnancy and they are likely to come to us when they are much older. And also there's IVF as well. And by then they are likely to have these non-communicable medical conditions. I did say that we have focused on direct causes of maternal mortality and neglected these non-communicable causes. Next slide. So when you are faced with a non-communicable condition, the key thing is to think in terms of the condition itself and then in terms of the pregnancy. In terms of the condition, we are asking ourselves questions. First of all, you've come to me, you're pregnant, you have this condition. Will the pregnancy worsen your condition? Like some cardiac conditions, then we would be advising on termination of the pregnancy on medical grounds because you might die from carrying the pregnancy. And then will the condition get better, worse, or remain the same? Different conditions behave differently in pregnancy. Have they been optimized by the primary caregiver, the GP, the family doctor, or the MO, or your physician? Then some investigations we do in pregnancy, are they safe? I left out important one, the medicines that the patient is taking, are they safe? They could be teratogenic. I also left out another important one. I'll update my slides. Lab values do change in pregnancies. So the ones that were in the non-pregnant situation might not apply in pregnancy. Second thing is patients might have different wishes from ourselves. They might have cancer. We are telling them, no, if you carry your baby, you're going to die from the cancer. Yes. And then they say, no, I do not want to start treatment. I want to carry the baby instead. So we always listen to the patients. Then in terms of pregnancy, it's thinking across the continuum, easy. So preconceptual, how to optimize things, then look at each trimester, what extra things you need to do, like the second trimester anomaly scan. In that trimester, for almost all patients with non-communicable conditions, we need to do serial scans. And then intrapartum considerations. These patients, when they come, a senior doctor, a registrar and above must be involved in having a labor management plan, which is then communicated to the rest of the team. And then postpartum breastfeeding, safe medication, transition of care back to the physician or the GP, and issues like contraception need to be discussed. In pregnancy, we see miscarriages, IUGR, preterm birth, fetal anomalies, and IUFDs. Next slide. About this, it's all about involving other teams, so multidisciplinary care, talking to their physician or GP. In situations where we have maternal medicine specialists or obstetric physicians, then they lead the care. Then we have joint antenatal and medical clinics happening together. And it's all about having combined care and forward planning. And the other thing I wanted to mention is once a patient is pregnant, remember our definition of maternal mortality is not only about obstetric issues. So if a patient comes to the ED at Kenyatta, for example, and the obstetric registrar is called to the ED to review this patient, or they're in a different team, a different ward by mistake, they need to be under the obstetric team. So whether they have other conditions, we need to be aware about them and we need to be involved in their care. Next slide. So in summary, I will say optimize the medical or the non-communicable condition before pregnancy, during pregnancy, manage and minimize risks, involve our neonatal colleagues with neonatal alerts about medications and conditions that patients have, and involvement of our neonatal colleagues at delivery. And I can't overemphasize multidisciplinary care. Next slide. I would like to recommend to you to buy those 2 books. The obstetricians, my obstetric colleagues. So get one of them. One of them is fine. So the green one is by Charlotte Fries, and the other one is Professor Catherine Nelson Pierce on obstetric medicine. It's a very good handbook to have in your office. When you get this condition, everything is summarized in a page and you can read. Look up those societies: International Society of Obstetric Medicine, MOMS, and then there's a Royal College of Physicians guideline on acute medical problems. Those are very important resources to have a look. The International Society of Obstetric Medicine has, if you follow them on Twitter, they have regular webinars and they are very good to join in. Next slide. Asanteni sana.
Thank you. Professor,
Yes.
I hand over to you, but before I do so, I just wanted to make a joke. We're always made fun of that we're 1%, but you can see 1% manages 100%. Thank you. Over to you, Professor.
Thank you very, very much, Dr. Githai, and thank you very much to both you and Dr. Anne-Marie for a very exciting start to this afternoon. We now change gear a little bit, and we have 3 more presentations, also very, very interesting. And we invite you to stay to the end when we'll have a discussion around these different topics. Now, without much wasting time, Dr. Tanya is actually a chief resident in pediatrics. She's carried out an interesting study looking at breast milk sodium as a surrogate of a marker of milk flow, and our study population are mothers who have babies in our newborn unit. So Dr. Tanya, please go ahead and use your time well so that we are efficient in running the session. Thank you.
Okay, thank you. Good afternoon. Thank you very much for this honor to present to these esteemed colleagues, most of whom are my teachers. So my study was on the prevalence and the factors associated with the adequate milk supply as measured by breast milk sodium among mothers of neonates who are admitted to the Kenyatta National Hospital newborn unit. Next slide, please. So suboptimal lactation is a common problem that's experienced by moms and their babies due to various issues. And these issues can be irregular feeding, poor feeding technique, pain in the mother, maternal fatigue, poor latching by the neonate, which are all modifiable. However, inadequate milk supply can cause many issues in the newborn, which include poor weight gain in the newborn and discouragement to breastfeed exclusively, and of course this might lead to increased morbidity and mortality. The breast milk sodium levels are a simple way of determining suboptimal lactation and predicting lactation failure. So when the milk is low, the breast milk sodium is high. Next slide, please. Here we've got a chart where you can see the red star that is about day 1 of life, the breast milk sodium should be around 60 millimoles or above, and this is in the colostrum. After this, from the 3rd day onward, there's a rapid decline of the levels of sodium, and this comes to around 15 or 16 between day 5 and day 7, which is the transitional milk, and thereafter we have the mature milk. So this is the normal physiology. Next slide, please. Now, previously, previous colleagues who have done studies on breast milk, we have Lavagno, who did a systematic review to describe the breastfeeding associated hyponatremia, and they were looking at neonates with hyponatremia, their clinical features, and the maternal factors associated with high sodium in the breast milk of these moms. So 56% of those case reports that they examined had significantly elevated breast milk sodium. They noted that the neonates present with poor feeding, decreased urine output, and weight loss. We have Manganaro in 2007, who examined the breast milk sodium in healthy, exclusively breastfed neonates. And they checked on the breast milk sodium levels, the neonatal sodium intake and milk intake, and the normal neonatal weight loss. They noted that a high breast milk sodium may indicate suboptimal lactogenesis, and breast milk sodium level is inversely related to a neonatal milk volume intake. The same group, Manganaro, had earlier done a study to determine the incidence of hyponatremic dehydration in exclusively breastfed neonates. Here they looked at the breast milk sodium levels, the neonatal sodium levels in their serum, and the weight loss, and the breastfeeding technique. Among these moms, 74% had a poor, inefficient breastfeeding technique, and 26% had low milk supply. Next slide, please. Now, my justification was that 99% of neonates in Kenya, according to the Kenya Demographic and Health Survey of 2014, are initiated on breastfeeding, but this declines to 81% at 1 month and 61% at 6 months. Majority of the causes of a low breast milk supply are preventable or reversible. So it would be important to know in our population what is the extent that's affected and what particular issues do they have. So in the normal physiology of breast milk sodium, the levels are inversely related to the breast milk supply. Again, high breast milk sodium indicates reduced breast milk supply. As much as in a country where we have very robust programs to promote exclusive breastfeeding, and majority of the moms are really enthusiastic to breastfeed exclusively, there is very little local evidence on the characteristics on those who don't exclusively breastfeed and those who experience inadequate milk supply. Next slide, please. So my question was, what is the prevalence and factors associated with the poor breast milk supply as measured by breast milk sodium among these moms, as mentioned before? My first objective was to determine the prevalence of poor breast milk supply using the breast milk sodium on day 5 to measure in the breast milk of the moms of this study population, to evaluate the association of breast milk adequacy as measured now by the breast milk sodium, the selected neonate measures. Specifically, I was looking at the number of wet diapers and the newborn weight change at day 5 of life. My secondary objective was to evaluate the association between selected modifiable inhibitors of lactation and adequacy of breast milk at day 5 postpartum among mother-newborn pairs in the KNH newborn unit. So factors that I was interested in were the technique, maternal pain or illness, and socioeconomic stress. Next slide, please. So these were my methods of next. Yes, so it was a hospital-based cross-sectional study in KNH. My inclusion criteria was that they were in the newborn unit by day 5, taking milk orally day 5, whether expressed or breastfeeding. The mother must have elected to breastfeed. A mom reporting low milk supply, this is at any point in those 5 days, informed consent from the mom. The exclusion criteria was that if the neonate was older than 5 days, if the gestation was less than 36 weeks, because physiologically these moms have a different characteristics of their milk. Moms who are too sick to breastfeed or express milk, or a mother who had chosen not to breastfeed. And I was sampling consecutively. Next. Oh, I don't know what's going on. Oh no. So it's not looking very clear, but I can just explain. For my first objective, I just used the Fisher's formula, and my intended sample size to fulfill objective 1 was 96. And for the second one, I used this InfoStat Calc version 7 using the Fleiss GL formula, and I was to get 90 people. So to account for any loss to follow-up, my total sample size was going to be 99. These are my clinical definitions. So low milk, at least one of the following: the mom reporting the low milk, and neonate measures. Okay, it's gone. It's okay. We can just carry on. Hello.
Just continue with the next slide. Yeah, thank you.
Next slide. Yeah, thank you. So weight loss of more than 7% by day 5, fewer than 6 wet diapers per day. So the breast milk sodium levels on day 5 and the interpretation, normal, as seen earlier, was to be less than 16 millimoles per liter, which would indicate an adequate breast milk. If it was elevated, it would be between 17 to 25, which is slight inadequacy. But a severe elevation of more than 26 would indicate inadequate breast milk. Next. So these were my procedures. I screened the neonates in the newborn unit on day 4, took consent, enrolled, and took relevant information from the files. On day 5, I interviewed the mom, weighed the baby, observed the breastfeeding, and performed a physical exam on both the mom and the baby. Depending on what the mom had expressed, I did some lactation counseling. Maybe for some of them, it was to demonstrate how to hold the baby appropriately. For others, how to express the milk appropriately, or to answer any breast milk related questions. Then I took a breast milk sample, 4 mLs, and thanked the mother for participating and transferred the samples to the lab. Next. Here are my results. So for the first objective, I screened 100 mom and infant pairs. 4 declined to participate. 3 pairs were willing to participate, but the moms had no milk at all. So my final sample size was 93 infant mother pairs. Next. These were the moms' characteristics. We had the moms who were less than 24 years being 30%. Majority were between 25 and 35, and we had a few older moms at around 14%. We had around 63% having had a cesarean section. Maternal complaints of pain, this we'll talk about later on, 78%, which is quite a large proportion. Parity, we had 41% being primary gravidas. The sleep we'll talk about later as well. Education, we had a majority of the moms having secondary or higher education to 73%, and a good number of the moms, almost 60%, were unemployed. In terms of income, we had a majority of the moms who didn't know what their income, household income was. Next slide, please. So in the neonatal characteristics, we had around 54% being male. The singletons were the predominant at around 96%. Only 21% of the neonates were referrals. Prematurity, who we defined as less than 37 completed weeks, were 25%, and the rest were term 37 plus at 75%. The mode of feeding, we had majority who were breastfeeding at around 61%, and the birth weights, majority of them were more than 2,500 grams at 76%. Next slide, please. So for objective 1 on the prevalence of poor breast milk supply, here you'll see what was the main finding of the study. If you look at this blue arrow where it is denoting less than 16, you'll see that there's not even one mom who had a normal breast milk sodium. All 100% of them, 93 moms, had more than 26 millimoles. So that means that we had a prevalence of inadequate breast milk supply of 100%, which was actually quite surprising. Initially, due to getting consecutive high breast milk sodium in my samples, I had to review what the lab was doing, their quality control, and having ensured that it was okay. We even took a few samples to an external lab, and they corroborated our findings because this was quite surprising. Next slide, please. So the objective 2, association with the the breast milk sodium and the wet diaper count. Since we had no moms in the normal group, we divided the moms into 2 groups using the median of 46.8 millimoles per liter. So the ones who were equal to or above, we labeled them extremely high, and high as those who had less than the median of 46.8. So we can see that the odds ratio here is 1.4 with a confidence interval of 0.8 to 2.3, which crosses the null value. So then the p-value of 0.15, which was not statistically significant. Next slide, please. Still on the same objective 2, we have the newborn weight change and breast milk sodium. Similarly, the group that had greater than desirable weight loss, which was more than 7%, this was 24%. The odds ratio was 1.2, sorry, and a confidence interval of, again, 0.8 to 1.8, which crossed the null value, and the p-value of 0.35, which is not statistically significant. Next slide, please. So this was my third objective, the modifiable factors. The breastfeeding technique, it was good. We had a fairly even distribution. We had the moms who had appropriate technique, which was 57%, and poor, which was 43%, and the odds ratio was 1.8. The mom's perception of her own capability to breastfeed. So if she feels that she will be able to breastfeed her neonate, and 75% of the moms were fairly confident that they would be, and 25% were not. Here we had an odds ratio of 0.6. So the moms who were more confident, the confidence was protective in a sense, but as you can see, the p-value was 0.1. So maternal fatigue, we'll talk about this a bit later, and the income. So those who had less than or equal to 10,000 Kenya shillings per month, and we had the group, it was almost equal, and those who had more than 10,000, the odds ratio is 1.1. Next slide, please. Now, here is where I feel like in the third objective, we had more to discuss was the moms, as you can see, those who slept more than 6 hours were only 6%, which meant that 94% of the moms had less than 6% of sleep. And that was actually quite a universal complaint that the moms, they on their own part said that they were quite tired, especially with the frequent moving around and the sleeping arrangements. Then education on feeds, the ones who are having no education at all in the sense of how to feed your baby, other than the fact that you should exclusively breastfeed. Any information beyond that, 70% of the moms had no information beyond that. They only knew that you must breastfeed your baby exclusively. The ones who 30% of them said that they had some information, it's important to know that a good number of those moms were moms who are attending the high-risk clinic at Kenyatta, and they had quite good information. In maternal pain, only 22% of the moms had no complaint. The rest of them, 78%, had at least one complaint or more, and you can see that some moms had 2 or even 3 complaints. Next slide, please. Now, these are some of the conversations that we had with the moms when I was interviewing them. One of the moms told me that I have too much pain to sleep and my pain medicine is over. And one of the other moms said that we frequently miss meals because of the time, the nursery, they have to be in the nursery, and the time the food is given, they often clash. One of the moms said, I feel like I just want to go and leave the babies here. I'm tired. This mom had twins, and I had to call a psychiatrist. Turns out she had postpartum depression. The other one said, the doctor told me I don't need any medication for pain because it was only just a small incision, but I can't sit or move comfortably. This is a mom who had an episiotomy and had been discharged from maternity care, was just around because of the neonate, but she was visibly in pain. She was really unable to sit properly. Then it is not possible to sleep because we are so many and I'm always uncomfortable. This was one of the moms describing to me the sleeping situation because they have to share beds, they have to sleep on the floor, which might be difficult for moms, especially post CS. Next. So conclusion. The mothers with newborns in KNH and BU had 100% prevalence of high breast milk sodium, suggesting a universal inadequacy of breast milk supply. The high breast milk sodium was associated with lower urine output of the babies with excessive baby weight loss by the 5th day. The poor breastfeeding technique, maternal fatigue, and lower income may be associated with lower milk supply, whereas higher maternal confidence may lower the risk of poor milk supply. Mothers in the newborn KNH have higher than expected levels of breast milk sodium, even among those who perceive themselves to have a good breast milk supply. Next. So the maternal discomfort and fatigue came out quite clearly that they need, I would suggest they get better sleeping or resting quarters. Maternal self-confidence, because the provision of maternal education would boost this, especially if they are aware of danger signs to look for both in themselves and in the neonates. Maternal physical pain. So I feel if a mom complains of pain, they should not be dismissed. The pain provision of analgesia is important, and the moms should be reviewed, especially for those who had issues, had to call a counselor for 5 months, and 2 of whom needed to be escalated to a psychiatrist. So this is important to take care of their psychological well-being. So the limitations of my study that I noted were that the moms don't really keep an accurate track of their wet diapers. There may be some recall bias, and they may be a higher than normal baseline stress because of the ongoing pandemic and its effects on income and social interactions, because they are reduced and social support is also markedly reduced. Next slide. Thank you. I think that's all. Thank you.
Yeah, thank you. Thank you very much, Dr. Tanya. I thought you'd talk to us about how many steps the mothers walk to go to see their babies per day.
Oh yes. So I used a pedometer and took the distance. It worked out to around 2 kilometers per day to go and see their babies and back. So as much as 2 kilometers doesn't sound a lot, but it has to be remembered in the context that this is a mom who's probably had some surgery or has had some issues. So yeah, it was around 200 and something steps each way to go to see the mom, to see the babies. But I think, Prof. Ndati, the thing that came out most clearly from the moms was that they're really uncomfortable. They're just saying this sleeping and this food arrangement. Actually, one of the moms says, how can I get milk and I'm not even eating? So you see that kind of thing. I feel like those are things that are really urgent and they can be addressed. They're very simple things, especially about food and all that. Yeah.
Okay, thank you very much, Dr. Tanya. We now go to the next presentation, and it's our colleague, Dr. Richard Aya, who's going to talk about health system and perinatal health. I believe a very timely topic after what we've listened to. Thank you, Dr. Aya.
Yeah, thank you very much, Prof. If you can confirm that you can hear me, I can see that the slides are there.
Oh yes, we can hear you loud and clear.
Thank you. Yeah, so a privilege to be presenting something a little bit on health systems and perinatal health. What, as we know, perinatal health is one of the major indicators of health system performance. So I'll just try and pick on one aspect of it, and I hope it's engaging. So next slide, please. So in terms of situational analysis, I think a lot of what is being presented in the symposium really explains what the situation is. What I've done is just try and present one or two facts. What I'm trying to put together is the health systems building blocks. So the ultimate is when we look at service delivery, and we do know that despite the investments that have been made, there's still inadequate service delivery. So one of the studies shows that despite facility-based deliveries going up, there hasn't really been a significant change in mortality figures, either maternal or in terms of perinatal. The other major thing is looking at health financing. And if any of you have just had a look at the recent budget, we have had over the last 10 years or so declining amounts of money being put in terms of health financing as a ratio of GDP. So with the amounts of money go up just a little bit, but as a percentage of GDP, it's going down even in the middle of COVID. So, and we know that at the clinical level, cost is a deterrent to health facility service utilization. One of the major principles of health systems in terms of outcomes is effectiveness and equity. And at a clinical level, we measure that by looking at quality of care. And we do know that there's an association between quality of care and patient utilization of services and patient satisfaction. One study that I found interesting and is this one done in KNH that showed a prevalence rate of preterm birth at 20.2%. One way of viewing that would be to say that that's a terrible thing. Another way would be to say, but that's actually where you expect to find preterm births happening. And therefore that's a good figure in quotes. Next slide. So I want to take us back and up in terms of looking at policy. So this figure comes from the Kenya Health Policy 2014-2030, and it looks at the various building blocks on your left in terms of policy orientation. So it's divided neatly according to the building blocks. So looking at health financing, the leadership, technologies, health information, workforce, which is what I'm going to talk about, and then service delivery. And then health infrastructure is something that Kenya has taken as a separate item out of the various building blocks. And what is there on the vertical are some of the principles. So equity, being people-centered, having participation, and so on. And if you look at the policy objectives, you could take these generic policy objectives and fit in perinatal health. So we just had a presentation from Dr. Macharia on communicable diseases. So you could take that and plug in the bit about perinatal health as well. Similarly, Dr. Murithi talked about the NCDs, and you could contextualize that for around perinatal health. But the overall policy goal is then to have better health, which again, we can contextualize in terms of various outcome figures. So one of the issues that I see when you look at health systems is that we don't take this and contextualize it to the levels that we're at, perhaps at the clinical levels, or even into maybe the meso level at institutional level. So there is a gap there in terms of people working on this to translate these policies into actual practice. Next slide. Next slide. So I've taken this slide, so I want to talk about 2 or 3 things now. And one of them are that the interventions that are associated, that are used to manage perinatal health. So about over 40% of the interventions in the Kenya Essential Package for Health are around maternal and newborn health. So a significant amount of resources are put to maternal and newborn health. And we know that the outcomes are not as good as they can be. Now, the point I'd like to make on this is for the audience to look at the tier where these services are provided. Most of them are at level 2, 3, which is at the health center level. So that is where we should have complete and comprehensive services for the various newborn services. I haven't put down the maternity, there's so many of them. But the major thing is that a lot of the discussion tends to be what happens at the level 4, 5, 6, whereas most of the services really should be happening at the level 2 and 3. And so there is a gap about how do we ensure that what is available at level 2 and 3 is adequate for the population in terms of effectiveness and equity, and that what filters up is really what should be managed at the higher level facility. Next slide, please. So this is another way of looking at it. So these interventions happen at these various facilities. So the catchment population is given. So a level 6 facility should have a catchment population of about 5 million. So in theory, we should be having 8 or 9 level 6 and above facilities. And we should be having about, we should have 8 or 9 of that. And we should be having around 1,500 health centers serving a population of about 30,000. Now, one way about thinking about the service level and the catchment population is that if you're thinking about perinatal health, that health center should have between 4 and 5 deliveries per day. So we can then begin to think about what kind of facilities, what kind of staffing do we need to be able to deliver 4 to 5. And if we're to take a complication rate of 15%, then we begin to think about what numbers need to move up to the primary facility and to the secondary level facility. So we can then begin to think about when we're planning the services, where the staff should be and what type of staff should we be having. Next slide. So this is some work that we did. So I was part of the team, the consulting team that developed the health norms and standards for human resources. And that led to the publishing of this document. And I'd just like to spend a little bit of time because I think it's useful. So a lot of people still plan using health worker to population ratios. Now that is useful at a very high level. It is not very useful when you're, for example, in a facility and trying to figure out what kind of human resource you need and what kind of equipment you need and so on. So the workload indicator staffing need developed by WHO and applied here in Kenya is what is being used. So some counties have taken it up quite well, others have not, being used to be able to place staff. So in order to work out what kind of staff is needed, we need to be able to identify what the standard workload is. So what the standard workload consists of is all the activities you expect that particular staff to perform. So for example, we would have a medical officer and we need to define what work does a medical officer do and how long does it take that medical officer to perform particular activity. So based on that and based on the population needs, you can begin to work out how many staff you need and what caliber of staff you need and what kind of training is needed for each particular staff. So that's the first level. And then you need to input, in addition to the specific core duties, the additional activities that they carry out. So for example, how much time does the individual staff spend on, say, management or record keeping or in meetings and so on. So this is just for the core staff, the line staff. And then there's this category called the individual allowance factor, which is that whenever you have a member of staff, say a doctor, for example, there is going to be somebody who is senior to them, say a consultant, who will spend some time doing additional duties that are not performed by the junior staff. So for example, a consultant will have to spend some time teaching, which may be more time than that is taken by somebody junior to them. So you add that factor in as well. And when you combine all these three, you get an idea about the staffing needs. So how many medical officers do we need to run a neonatal unit, for example, or a pediatric unit, for example? How many nurses do we need? Now, as that is done and calculated, then you also get an idea about what kind of equipment do they need in order to perform their duties properly. So when we did this work, one of the major things that came out of it, we made so many assumptions, but one of the major things that came out of it was that there was then a need for the professional associations to validate, especially the standard workload, and to also devise a means to be able to continually update as technology changes, as targets are met or not met. So a way of having a good M&E system at a professional clinical level. Next slide. So I should actually have labeled this slide as "it depends," because this is probably one of the most frustrating bits of trying to get this whole thing working. So when you ask clinicians in terms of how do we calculate activity, what does a medical officer do? The typical answer you get back is, it depends. Now, that it depends, when I hear it, it's like partly a problem in terms of perhaps the tools to be able to work it out, but partly also a power thing, if you look at it from a political perspective. In this sense, as long as somebody replies, it depends, it means that you have to rely on them to do what they want when they want to do it. And that is the gap that then exists between the political leadership who are holding the resources and the clinical leadership who have to carry out the work. So you hear it depends, and that means that no information is forthcoming. And so we have this big gap because the political leadership and those managers who are entrusted to implement the work in the health system are not going to go and read big textbooks of medicine or to keep up with the latest in terms of scientific research, nor should they. So this, to me, is the job of the clinical leadership, to be able to translate that which is in the clinical sphere and put it in a form that the political leadership can understand and be able to implement. So listening in, and we've done quite a bit on trying to put these policies together so I'll give you one example. In a group working with UNFPA, we worked out what should be the targets for SDG for Kenya around maternal health. Now, when we did the work, a lot of it depends on availability in terms of service delivery, resources, and so on. But there's a significant bit, and that's actually the gap that you see there. It's roughly 3%, so 2-3% in terms of leadership support, political will to support health targets. Now, where it is often missing, it's missing because this dialogue between the clinical leadership and the political leadership is not there. There's a lot of antagonism, and that therefore affects the patient outcomes. So one way of narrowing this gap is for the clinical leadership to be able to work out what are the needs in terms of using a Wizen approach. So what activities should be carried out, but now translated into the actual levels of care. Next slide. So I've run through this really, really quickly, trying to, given the time. The point that I was trying to make is that we know that perinatal health is a major issue. The perspective I've taken is that addressing this means that we need to work on our clinical leadership, and especially in terms of communication with the political leadership who hold the resources that are needed to implement the service delivery that is required for us to get good patient outcomes. And one tool that we have already is the Wizen, and the work that needs to be done is at the professional level to be able to translate the clinical SOPs into non-medical language, if that makes sense. Thank you very much.
Thank you very much, Dr. Aya. Thank you very much. We now, those who have questions around that presentation, please post it to a chat. We'll come back to a question and answer session. We now go to the last presentation for this afternoon, and this is Dr. Edwin Walong. Dr. Walong is a pathologist, and he'll be presenting to us forensic findings in perinatal health.
Right. Thank you very much, Professor, for the introduction. And again, just as the other presenters have echoed, one of my favorite memories is sitting with you through an autopsy when I was early in my, on the early days of my training. And I really appreciate the mentorship you've offered through the years. So I'm a pathologist, and my presentation today will focus a bit on the autopsy. I know the title is on forensics. Usually most people, when they mention forensic, they mean the autopsy or the death investigation. And just to contrast on what we do see in our news, this was a major news item 2 years ago from Japan concerning newborn health, and it pushed the frontiers of newborn survival. But unfortunately, this was our major news items then, and some of them were focusing on the adverse outcomes we do see on maternal mortality. And indeed, 2 years ago, you all saw this news item about the number of mortalities that occur within this age group. So we may express them nicely as ratios and rates, but when you look at absolute figures, they're actually quite heavy. At KNH, we sometimes do see double this number. And of course, with this presentation, we're also humbled to realize that what you are seeing as very bad news in maybe Kiambu County is actually what the best situation in the country, with some areas averaging almost three times that rate. So it shows that this perinatal pathology has to be taken, cannot be taken lightly. Again, if you look at overall causes of death, perinatal conditions ranks second, and overall causes of disability. And in this, within the Kenyan strategic plan, it captured actually 2 points where perinatal pathology was prominent. And as Dr. Aya has mentioned, if you look at it from an epidemiologist's perspective, perinatal mortality has remained pretty flat, while all other metrics of pediatric pathology have been improving. So there's still a lot of work to be done. So basically what I'm summarizing is that there's lack of high quality mortality data, and the mortality data focuses on who dies from what, which is the most basic health statistics. And the fact that we do not know this for more than 2/3 of the world's population, more so in developing countries, means that a lot of interventions are constrained in their nature. And then of course, we are focused on identifying the cause of death, which is the most basic health statistic, which I will look at. So this is a quote from one of the leading pathology textbooks in pediatrics, where we do perform investigations of the dead infant, but this investigation is usually of no value if it's an isolated piece of information, but we must integrate this to various aspects of heredity, conception, development, intrauterine environment, and behavior, so that it becomes part of this important chronicle. So I will go forth and share a few cases where neonatal autopsy, or just to highlight how neonatal and stillbirth autopsy, the technical aspects of it. Then I will also use these presentations to highlight cause of death determination and potential use of the mortality data. And I'll finally describe the minimally invasive approach, which we have been applying in this country quite a bit. So I'm going to use a few pictures and illustrations, which may be of a distressing nature. but I'm using them purely for educational purposes. So I'll go forth to one of my most recent cases, and this is a stillbirth that occurred at 30 weeks. And from the pictures, the pediatricians, rarely do pediatricians see this, but the gynecologists can already see that this is a truly macerated stillbirth with a post-mortem interval in excess of 12 hours. But the actual pathology was in the placenta. And what caused the actual mortality is this massive abruption, which we are seeing on the polar aspect of this placenta. And here are those blood clots that we're describing again. And here are the other pieces of the placenta. And when we did the cut-up of the placenta, we can see that most of the placenta is quite pale, suggesting an insufficient pathology as well. And based on this, we identified the immediate cause of death as acute intrapartum asphyxia, especially due to the negative nature of the autopsy and specific brain findings due to placental abruption. And we were suspicious of blunt force traumatic injuries involving the mother. Now, I do have a question for all of you, which I hope you will type in the QA section. In case one, how would you consider this a preventable death? And if so, how? So basically, one of the areas I'm highlighting in the fetal autopsy and stillbirth autopsy is that the placenta is what will give us the idea of the maternal diagnosis. And you will see that in our cause of death formulation, the maternal diagnosis is very important to complete the actual causal pathway related to that mortality. And I know Professor Bimbo may have taken time to discuss this. Now, here's another case of an early neonatal death, and we've already performed the thoracoabdominal incision, just showing that all the organs are in the right place. However, there is an unusual mass protruding from the mouth of this second case. And when we examine it keenly, you can see that there are certain structures. First, it's a hydropic. There is a marked edema. And this mass was attached to the palate, and some of the pieces of this mass was extruded from the nose. And when we performed a dissection of this mass, we identified that this was actually a second twin, a conjoined twin. And the reason we were performing this autopsy was because this diagnosis was entirely missed on prenatal testing. So how did we determine this? How did we document the final cause of death? Again, the aspect that I'm introducing is the use of the WHO International Classification Disease version 10, perinatal mortality rules for assigning causes of death, where the first item is the immediate cause of death, and it's the disease process that had the shortest duration to death. And once we identify the immediate cause of death, we look for what is causing it, the causal pathway. And here, the causal pathway, we can see that there is a cephalopegas attached to the palate with evidence of twin reversed arterial perfusion, intrauterine growth retardation, and fetal death. And of course, there is always a maternal diagnosis that we must always link to that cause of death. And if you do not identify this causal pathway, then we are unable to contextualize this death in the situational aspect. For example, the next question, of course, I will have for you will be, what will be done to prevent this? The first question is whether this is truly a preventable death. And when we highlight causes of death in this manner, then you can identify how to deal with each section. For example, the immediate cause of death is what the neonatologist may be dealing with at that particular time. The events leading to it, maybe the situations that the gynecologist or obstetrician should have dealt with or should be dealing with also at that particular time. And of course, we can always go back to see what in the system led to this. So again, is this a preventable death? And if so, how? And you'll add another question. If you did not know the cause of death, or if the cause of death was not expressed in this coherent manner, would you be able to identify whether truly this is a preventable death or not? And will you be able to identify whether whether interventions can be taken for this? One third case is this one, where this was a mother who was assaulted by someone she knows, and the unborn, the term fetus, who was still unborn at that time, actually bore the brunt of the injuries. What I'm trying to show here is a spleen with a splenic rupture right here, and there was intra-abdominal hemorrhage, and of course we are seeing intracranial hemorrhage as well as contusions to the head. And again, we are looking at a cause of death, which is an acute intrapartum asphyxia related to placental abruption. And of course, we are looking at abdominal trauma, and of course, trauma to that child. And this one, of course, will be the very straightforward forensic case involving the fetus in this circumstance. But then again, the reason we are performing these autopsies are not so that we can send people to the police and have them prosecuted. Of course, that's an important thing, but raise various questions about whether these deaths are preventable, and if so, how. And again, I'm interested in your opinions. Now, the final case that I'm going to show you is the brain, and this is the brain of a 1-day-old fetus who had apnea immediately after delivery. And what you can see is that there is a global subarachnoid hemorrhage, which is, and of course, there are various, because of the hemorrhagic pathology, there are various features we are seeing here also in the brain. This was to show a contusion at one part. Particularly, this is an example of birth trauma. And this is a patient who had apnea after delivery. So he was delivered, and the mother reported apnea, and eventually the baby was declared dead. So cause of death, we are looking at traumatic birth injury here, okay, which is characterized by subdural hemorrhage, contusion, cerebral edema, and it occurred during cesarean section delivery of a preterm newborn. And the mother had, the reason for preterm delivery was due to maternal abdominal endometriosis. So again, this is just to highlight that a maternal diagnosis has to be part and parcel of the diagnostic formulation as we assign causes of perinatal deaths. And I rarely see that in the deaths that we do investigate. And you can imagine how lack of that information will constrain Dr. Ayer's team and additional teams from identifying various patterns in the population that will prevent most of these deaths. So again, do you see this as a preventable death, and how? So the reason I've presented the 3 cases is to highlight what a cause of death is. And the cause of death is a diagnosis, usually a disease leading to death. And once we've identified that particular disease leading to death, we identify its causal pathway, meaning that what are the other diseases related causally with that immediate cause of death. And of course, the maternal disease is very important when we use WHO ICD-10 perinatal mortality protocols. And once we have information on cause of death, then we can start making inferences for each individual causes or each individual mortalities in identifying whether the mortality is preventable or not. Now, there's another parameter, or rather another, the next is a manner of death. And you can see I've deliberately avoided describing manner of death in today's talk because it variously defines the circumstances relating to death. And it has various examples, whether it's natural or unnatural. And if it's natural, it's due to internal disease processes usually. If it's unnatural, it tends to be due to external disease processes. And we tend to use this, we do further subclassify unnatural or external causes as homicide, suicide, or accidental death. And if there's an accidental manner of death, then we identify whether there is medical error versus other external causes. Usually, the manner of death is assigned usually through a medical jurisprudence process, meaning that there should be an inquest held, usually by a magistrate. And what you will realize is that most deaths that we investigate in the perinatal age group do not occur in the context of forensics. They do occur in the context of clinical care and surveillance. Coroners can also assign manner of death. But what we would prefer, especially during your mortality meetings, is to identify whether each death is preventable or not. Now, finally, I'll discuss briefly about minimally invasive tissue sampling. So you have seen that the complete diagnostic autopsy that I have presented is a difficult procedure to perform. It's a medical and surgical procedure on a deceased person to identify cause of death. And you can see that by properly visually inspecting the organs and performing additional diagnostic tests in the laboratory, we can assign causes of death, and indeed that is a gold standard. But unfortunately, we do not have that luxury in many institutions, and even in our institution where we do have the luxury or the facilities for it, it is particularly difficult to implement. So the next best approach is a minimally invasive technique where we use core biopsy needles to obtain and additional needles to obtain specimens for a pathology-informed cause of death determination, where we can perform histopathology, virology, and microbial culture. And to put this in context, this is the usual flow of information in projects where we are applying minimally invasive and generally autopsy research, where we have to aggregate information from socioeconomics to clinical and then and laboratory testing, combine that with information from minimally invasive sampling, standard autopsies, and then present all this information to a panel of experts to decide on primary and secondary causes of mortality. So we have pilot projects going on in Kenyatta National Hospital and Bagathi, focusing on neonatal sepsis, adult COVID, and in Western Kenya, some of you may be familiar with the CHAMPS protocol. So this is my colleague, Dr. Wasike, whose work I'll also share here with his permission, and I'm assuming he's in the audience here. And Dr. Wasike is a senior registrar in pathology, about to complete his, and this was his master's thesis, where he performed 49 minimally invasive autopsies in newborns to identify the etiology of neonatal sepsis. These two ladies are medical students assisting in the work. And his work focused on microbial cultures and isolates, and he has identified, and I know Dr. Anne-Marie is looking at this diagram with a lot of interest, and identified that in our institution, most of the isolates are usually due to multi-drug resistant organisms, particularly Klebsiella and pneumonia. And the fact that a lot of this information that we found post-mortem tends, and what he has put in red, identifies the ones that were identified ante-mortem, and therefore identifies truly that there is concordance, and the fact that an individual, an infection that's present before death will actually be found post-mortem, whether antimicrobial use was, regardless of the status of antimicrobial use. But of course, we will discuss this study at a different point. But one of the areas that really interested us in his work is that when we examine specimens from the brain obtained by the minimally invasive autopsies, we found two cases in which we are seeing, and this is a brain histology, we are seeing astrocytic glial nodules, or what we describe as neuronophagia, where we have aggregates of astrocytes surrounding the neurons, and that would be a dying neuron. And we tend to see this in perinatal infectious diseases that are neuronotrophic. And this was a particular finding in Zika-related neonatal neuronal pathology. So it has we have identified that we may not be diagnosing certain diseases of the brain that may be congenital in nature. Right, so this is my final slide. And well, you have seen that the perinatal autopsy is technically demanding and requires trained personnel, facilities, diagnostics. And as much as a lot of it will be performed as part of research, we think it should be fully integrated into care. And as Dr. Aya has mentioned, perhaps in level 1. And the complete autopsy, which is preferable, we find that is preferable for situations which involve medical jurisprudence. And of course, where we have subspecialties in clinical practice and research. For example, we had a discussion concerning CNS, particularly neuropathology of the newborn at our institution. And the only way we can obtain certain insights regarding neuropathologic entities within this population is to perform a series of autopsies that involve complete diagnostic autopsy with detailed evaluation of neuropathology, as you saw in the birth trauma case. So we use minimally invasive tissue sampling for surveillance, but then we've realized that we can also use it for in various clinical circumstances where the complete autopsy is not possible at that point. And the overall objective of a pathology-based cause of death determination is to prevent similar mortality by identifying areas that require renewed focus. And I'm still curious to see what you've posted in the Q&A session concerning the cases that I have presented. And we definitely need to do a lot more autopsy-driven implementation science projects, particularly outside the confines of forensic work. So autopsy is an important tool for forensics, but indeed it's also an indispensable tool for clinical work. And our target would be a 30% autopsy rate, would identify a lot of these conditions and improve overall the clinical care that is offered. Right, so of course I have many people to acknowledge. Thank you very much, Professor Nduati, Professor Wamalwa, and the teams that are working within the CHAMPS projects, and of course my colleagues at the University of Nairobi and Kenyatta National Hospital.
Thank you so much, Dr. Along. Thank you very much for a brilliant presentation. We have now come to the end of the formal presentations for this afternoon, and we now will spend a few minutes responding to questions that have been said. Dr. Anne Hara, are you still around? Do you want to run that session, or?
You can continue, Prof.
Okay. So, Dr. Maureen, where are you? May I delegate that to you to?
Thank you, Prof. You
Yes.
may once you've delegated to Nakwata Amri.
Yes. Okay, please go ahead and run with the session. Thank you.
Okay, thank you, Professor. So let me just go back to my full screen. So I think in the chat, I think people can respond, but in the Q&A, there was a question on enlightenment. I think this is to Anne-Marie on presumptive rollout of ART stage 4. Don't know, Anne-Marie, if you can give us an answer to that.
Okay. I'm not sure what you mean by rollout stage 4. Maybe you're asking about the rollout of the newer formulations of the pediatric formulations. So like the DTG 10 milligrams. So those were to be rolled out by mid-year, but now it's looking like they will be available later in the year. The 4-in-1 that has abacavir, 3-TC, lopinavir, ritonavir, I think has been shelved in favor of DTG. So we expect like optimized for formulations for pediatrics later this year. So Mark Sifuna, you can let me know if that is what you were referring to by rule out stage 4, because I'm not sure.
Okay, then
Thank
someone
you.
is requesting for the link for your link details for your placebo-based studies. So if you could just maybe post to them directly. And then there's a question from Sylvester Kivindu. Can urine sample be used for TB diagnosis in children?
Yes, okay. I'm just gonna have to scroll down a bit, Maureen. I'm seeing Sylvester has asked 2 things. The initial diagnostic test for HIV infected children are suspected of having TB, and if the urine samples can be used. So I can answer those 2 together. So initial diagnostics for children will include getting whatever sample that you can. For example, if it is sputum in a child who is less than a year, you will get a gastric aspirate. For an older child, you may get induced sputum, which you will take. For AFB staining, for gene expert, for culture, the usual chest x-ray, Mantoux test, and sampling any other fluids. For example, if they're enlarged nodes, if there is an acidic fluid, if there is pleural fluid, you may want to do like a pleural tap. But diagnosis of TB in children, I want to emphasize, is a clinical diagnosis. Because they tend to have paucibacillary disease, rarely do you get a confirmatory gene expert. So not being able to identify TB bacilli does not rule out TB. And we should rely more on the WHO criteria, where we have what I like to call asymptoms. So either cough, fever, weight loss and failure to thrive, or reduced activity and reduced play. And you can see those are such non-specific type symptoms taken together with suggestive signs and symptoms, be they radiological, be they pulmonary, having a suggestive chest x-ray, having a positive Mantoux or interferon gamma release assay, and positive history of contact. So if you have any 2 of either of those in those categories, you can actually justify treating TB in the child. And where you're suspecting extrapulmonary TB, you substitute that cough for whatever other system you think is involved. For example, is it a subacute meningitis? Is there lymph node enlargement? Is there spinal TB that is then presenting with fever, night sweats, weight loss? But you investigate, because remember, some of those also fit in other diagnoses like malignancies. So to your other question on the use of urinary tests, you can use a urinary lab, that is a urinary lipoarabinomannan. Yeah, so just one of the polysaccharides that is found on the outer part of the mycobacteria. And this has been found to have higher sensitivity when CD4 count is low. So because I've said it's really a diagnosis that you're trying to just put together all the evidence for it, you can certainly go ahead to use a urine sample for your urinary lamp. Thank you.
Thank you.
It just needs almost its own day. Yeah, thank you.
I think it was a fantastic presentation. Just because you're already speaking, to make it easy, and I'm not seeing any more questions for you, just on your slide for prevention. I don't know, I'm an obstetrician, and as far as I know, we're not having the vaginal ring in routine use in the country. Any particular reason why you put that?
I put that because I was talking to your colleague, Dr. Kehara. Like you said, we are just joined at the hip. So as I looked at some obstetric aspects, I had to also seek some advice, and she's the one who talked about the vaginal ring, but I'm not aware about its use in country. So maybe Dr. Kehara, you'll clarify? Thank you.
Well, it has been piloted and has been found to be efficacious. So I presume in the family planning armamentarium, it should be one of the products we should be looking to roll out and scale up.
Which khaki? Which is your car?
Thank you. Thank you, Dr. Kihara, on that clarification. We're looking forward to using it in routine clinical practice. So I think, I don't know if that's Dr. Walong.
will show you.
Yeah, but she's not actually again.
There's somebody who,
Dr. Walong, please mute yourself.
IT, can you mute the person?
However, I would like Dr. Walong to answer questions because the next one is. Hello,
Sorry
Dr.
about
Walong.
that.
No problem. So for Dr. Walong, there was just a comment that there are few autopsy requests. Then there were comments regarding your cases, and Ian Mutai and I think Odongo Odio are the people who replied to your questions. So they said the first case was preventable. It was an early diagnosis of abruption, and early intervention might have prevented death. The first, then there was Dr. Odongo Odio. The first, second, and fourth cases, I think the only 3 cases, were all preventable. So probably from you, Dr. Walong, as far as you're concerned, in my opinion, for the abruption, you don't know what led to the abruption. Maybe it was high blood pressure or something. The death itself, depending on how soon the abruption happened, most probably could have been preventable, but sometimes not necessarily. So I don't know, what were your opinions? Now you can give us the answers.
Right. And again, as Dr. Chokwe has mentioned in the chat, we do not have all answers as pathologists. We have to, again, rely or bring the information back to a panel of specialists and particularly individuals who are providing clinical care and those who have some idea on the epidemiology or disease trends within that population to piece things together. So some of them, we really could not piece the things together and identify what is truly causing abruption. So we did hypothesize in one that there may have been abdominal trauma to the mother because from the clinical history, we couldn't find anything else. And in the other, there was actual history of trauma to the abdomen. So again, it just shows that pathology does not work on its own. It's not information. It doesn't really stand on its own right or basis. It just presents information that again has to be correlated with information obtained from clinical work and of course the other antenatal information, antemortem information available. Okay. But thank you for those questions. I see there are a few people from the CHAMPS project who may comment. Maybe you can write what your experience is in trying to relate this kind of information. Agri, I've seen you. Thanks.
Okay, thank you very much, Dr. Walong. Prof. Dwight, I don't know if you have any questions for Dr. Walong.
Yes, there are some more questions on the chat box.
Yes, I was going to the chat box. On the chat box, I'll start with at the top so that we don't miss anything. So I think the initial questions were for Dr. Gidai, but I think a lot of them were congratulating and thanking for a very stimulating presentation. And then Professor Mondiagutu asked about what is your take on situations where a consultant is not willing to come when consultant and asked to come but declines, and there's no one nearby to assist, commenting the liability status of the resident doctor and in the event of a poor outcome in this case. I think, Dr. Gidai, are you with us?
Yes, I'm here. Yes. You want me to comment on the liability of the student doctor when the consultant does not come? Yeah. I think if I can give a perspective of where I am and what I think, I do not think that any doctor who recognizes their limitations and weighs that in terms of their strengths and decides that I need help and calls for help, and then the help doesn't come, they should not be held responsible for the poor outcome. Actually, they should be congratulated or appreciated for being a safe doctor, because a safe doctor is one who recognizes their limitations and asks for help. The responsibility should fall squarely on the shoulders of the supervising consultant. If indeed they were called and they did not come to the hospital, that should be a disciplinary issue with the institution as well as with the medical regulatory authority. When somebody is on call, they should be available. There should also be mechanisms to cover for that. So can the gynae consultant come and help? Can there be a second obstetric consultant at home who is not necessarily coming to hospital, but they can be called in case the first consultant needs help, or if they are caught up, natural things can happen on the way to hospital. So that's the other thing. In terms of, remember I said earlier that obstetrics is an acute specialty. Most of the times things happen very fast. And we have to think about, one, consultants that we employ, where are they when they're supposed to be on call? How far away are they from the hospital? how soon can they come? For example, the standard in the United Kingdom is that a consultant must leave within 25 minutes of the hospital. And now we have gone to consultant presence on the delivery suite. So the consultant stays on the delivery suite until around 11 p.m. So they will do the round and ensure that the plans are in place. So because obstetrics is an acute specialty, I think we need to think about our staffing patterns and how we can support that so that residents are not exposed to risk. Thank you very much.
Thank you very much, Dr. Gidai. There were also several comments on the same, with I think expressing similar views. Then there were also some comments how we could be probably more inclusive of other cadres based on your presentation, that it should involve everybody and not even just the medical, but also non-medical workers. For me, I'd just like to, I think, just a few comments as owner, as the current office bearer in the Department of Kenyatta National Hospital. In regards to high power distance, I think since you are an undergraduate, fortunately, I'd like to say that I think things have changed and that distance has reduced. It has not been eliminated completely, but I believe that that power distance has reduced. Then regarding training, as a unit, we have been conducting a lot of the advanced life support in obstetrics. However, and as a hospital, you find also, I think there's the neonatal, I can't remember what the training is called. And you find in both groups, we're including people in the pediatric department to train in also. And we are included in their trainings for neonatal and perinatal mortality, the trainings that they have, that people from the obstetric team are being done. So in as much as it's not wholesome, but there is some level of collaboration. And recently there's an initiative inviting the obstetricians are invited to the neonatal mortality meetings, and we're also inviting the pediatricians to our maternal mortality meetings. We used to have joint meetings, so I think we can, following this meeting, we can progress how we can have just one meeting for the same. If we can move on to other comments. There was, please comment on the role of verbal, I think this is to Dr. Walong, on the role of verbal autopsy in perinatal deaths, especially level 2, 3, and this is from Professor Wanyoro.
I thank you, Professor, for mentioning verbal autopsy. And of course, verbal autopsy merits a discussion on its own, and it's also a powerful tool in identifying causes of death. The challenge is that in perinatal mortality, the diagnostic categories are usually few. I can identify at least about 5 broad diagnostic categories if you put it through the algorithm. But that is still much better than having no information at all. And again, I can see Dr. Muredi has asked about MRI and virtual autopsies. And for us, we consider use of imaging as a tool for directing the minimally invasive autopsy so that we can have higher quality specimens for a pathology-informed cause of death. But of course, it does have a role. Right, thank you very much for that.
Thank you very much, Dr. Along, and that was a very interesting presentation. I don't know if Dr. Tanya is still with us.
Yeah, I am.
Hi, Dr. Tanya, how are you?
Fine, thank you. How are you?
I think that was an excellent research with very interesting findings on your pedometer, which Professor Ndwati reminded you about. Personally, from an obstetric perspective, I'm actually pleased that our women are working. You find that from Dr. Gidai's talks, we're talking about non-communicable diseases and the issue of thromboembolic disorders. This is one of the methods we reduce thromboembolic disease in our postpartum, understanding that it actually increases in the postpartum period. You've pointed out that these are women who have undergone cesarean section. So in as much as it is forced, I'm happy about that. I'm definitely concerned about their level of pain management and their sleeping and the food. And I'm actually very happy that we heard that. So I think it's something we can take up with the nutrition and the ward in charges to see how we can make a more friendly environment. However, the duration of your study, I find it was just very recent. It was in April and May of this year, whereby we have not been having the craziness. So I'm quite surprised that the women are not having are sharing beds, because I've been in the wards, and I was just even in a ward round yesterday, and we're not having that situation, but we can look into that. On the 100% prevalence of what do you call it, low breast milk and the high sodium. However, if you look at your inclusion criteria, it's like you are bound to get that because you're including any woman who is reporting to have low breast milk. So I don't know, would that be the correct parameter to indicate prevalence? Because if you are maybe screening all women who are maybe whose babies were admitted in the newborn unit, rather than just those who had low, because for me that is an expected finding based on your inclusion criteria. So, but otherwise, a very interesting study. Thank you.
I can just make a comment on that last thing. There's a concept in breast milk supply of true low breast milk and perceived low breast milk. In it was not clear, but in my sample size calculation, there was a similar study that was done by some colleagues in India called Meta, and they found that the moms would complain of low milk, but among those who complained of low milk, only 53% had true low milk. Because as you can imagine, this is a time in which the moms are not feeling particularly themselves, they're distressed, their babies are ill, so they may feel like they have low milk when in actual fact, they don't have low milk. That's why it's important to use the breast milk supply, or in other places they use the decline or the rising of the lactate to tell if somebody actually truly has sufficient or insufficient milk. Yeah. And as to speaking to the pedometer, yes, it's very true that the moms do need to walk, but you should think about the type of walk that they're having, especially if they're sleeping on the third floor, they're being jostled by people during the visiting hours. That's what we mean. Like the walking itself it's fine, but it's an uncomfortable way to do it. And as to the sleeping conditions, I think in the ones who are still admitted, the ones who are still receiving care, they are okay. But the moms who have been discharged, or the moms who are just there for the babies, their sleeping conditions are really quite deplorable. I think in GFB, room 5, GFA, actually it's most of the room 5s, and then some of the moms are housed in 3D isolation rooms. So if you go there, the moms are sleeping some on the floor, on multiple on those really thin green mattresses. So those are the moms that are of concern, because these other moms who are still within the obstetric care, they're really quite okay. But the others who are there for their babies are the ones who are uncomfortable. Yeah.
It's a big challenge on the issue of how to take care of these women and jurisdiction they lie under. We'll not finish that conversation. We'll never agree with pediatricians. But unfortunately, it's a situation, but I think food for thought, and I think we need to come together and really come up with a solution for these particular mothers. I don't know, Professor Ndwati, if you have
thank you very much, Maureen. It's been a pleasure to share with you. I don't have any more additional comments to make. And I'm of course, you're sure that I'm very unhappy about these findings about among these women and what it means in terms of long-term lactation for them. But as you say, we will find a solution. We work together. We are a team. And I think between us, the institution and the university, we should come up with some good solutions. And just to thank all the presenters. I mean, these have been excellent presentations, very eye-opening. Dr. Gidai, we appreciate you taking time off. You know, you're in a different time zone, but to be with us in this meeting, we really appreciate. Thank you very much. I also want to thank. Yes.
Sorry, I know we're closing, but there's a jointly kindly question. We currently have so many cases of nursery incubator infant deaths and burns. What causes this? And if a mother cannot afford forensic fees but suspects negligence, should the hospital cater for the cost? I don't know. Sorry for taking us back, but there's just a journey come lately, and we didn't have that many questions.
Please repeat that, Maureen. Just repeat that question.
We currently have so many cases of nursery incubator infant deaths and burns. What causes this? And if a mother cannot afford forensic fees but suspects negligence, should the hospital cater for the cost?
That sounds like a question directed to me.
Yes.
And a hard question at that.
We will assist.
Well, I haven't seen that in my practice, but I'd definitely be interested to investigate any of this if they do occur. And once we do that, of course, with the additional biomedical and clinical teams, we should identify that we should do a root cause analysis. About access to care in forensic pathology, of course, that's a big problem because you've seen how difficult it is to perform a good autopsy. And should hospitals cater for the cost? I think I'm glad there are hospital leaders here who have a quality assurance budget, and I know some of the private hospitals do. And the KNH has also been very gracious in giving us facilities to do this work. And I think they do a good job of waiving a lot of these autopsy fees for most cases. So I think hospitals definitely should budget for this. Thank you. Back to you, Dr.
Okay, yeah, sorry. Thank you. And regarding that, I think on the hospital fees, normally, like for maternal mortality, I think Dr. Long has been very, very instrumental. If we, as the hospital, feel we really need an autopsy report for a particular patient, there is a mechanism whereby we can request for it and have the fees waived for the autopsy to be done. However, if somebody is accusing you, what the hospital will cater for would be the costs of their pathologist who would be representing them, because the time somebody is suspecting negligence, it's not medical legal. So in such situations, there'll normally be a pathologist representing the hospital and a pathologist representing the person who is feels that there's suspecting negligence. So they would have to cater for their own costs. So I don't know if I've answered that particular question, but as Professor Ndwati has said, I think I'll hand over. She was doing a fantastic job on thanking all the presenters, and it has likewise been a pleasure and an honor to chair with you. Professor Ndwati, final words over to you.
Okay, thank you very much. Just that one last comment, that the Department of Pediatrics, now KNH, the Division of Pediatrics, regularly looks at mortality. Every month we discuss whatever mortality we have. We've not seen or had reports of babies dying because they got burnt in an incubator. So at least within our own practice in KNH, we've not made this observation. But I'd like to encourage whoever asked that question to reach out. It may be that there's a special situation in a unit. It may be that you have incubators that are faulty, their temperature regulation is not correct, and that matter should be corrected. I recall being a young doctor running into problems where many years ago, giving ORS for diarrhea, and the children just got worse and worse, and we had many deaths. That was in Nyeri. We reached out to the departments and they came and were able to sort us out that whatever we were calling ORS was not correctly constituted. And once that was identified, then we were able to stop those deaths. So it's important, if you see something unusual, just reach out and somebody will come down to the ground to try and sort out, to try and look and see whether they can figure out where the problem is. Now, having said that, I just want to say thank you very much to everybody. I think our conference is not over. Even tomorrow we have sessions again from 2 o'clock and want to invite you for that. I also see that we are the announcements around the 5th International Conference of the Joint Conference of College of Health Sciences and Kenyatta National Hospital. They're starting to receive abstracts. I think this is another very important forum for presenting your work and learning from each other. So now let me hand over back to Dr. Kihara, who is one of the conveners of this forum. And as I do that, thank you very much to IT. You did a great job. Thank you very much. This KNH platform has really been a brilliant place for training. I noticed that when we had maximum attendance, we had almost 900 people in the session, so that is really good. Thank you very much. So over to you, Dr. Kihara. Thank you.
Thank you. Thank you very much, the moderators, Professor Ruth Duati and Dr. Maureen Owiti. I must appreciate all the presenters. I spoke yesterday about a tripartite arrangement. We need maternal twinned with perinatal, but also twinned with the health system. The collaborative team, I think we cannot run away from it. And even where there may be quasi-collaboration that is not working, I think it behoves all of us to be very keen on documentation, because what's not documented is not done. So whichever legal area you will go, whether it's an error or malpractice or absolute negligence, we actually fall back to what have you documented and what does your system provide as the tools or checklists when you're actually conducting or providing care pathways. So documentation is critical. The other thing I don't want us to lose sight of is for the mothers who have young babies and are paratrooping, as I have learned today, over 2 kilometers, is we need to really think about the psychosocial element that this lady is also carrying along with her, because that in and of itself can even be affecting milk production, particularly when you have a very sick baby or even baby demise. So we need to really think, should we start putting up, probably Maureen Owiti and Professor Duati, have maybe some form of counseling for these ladies such that it becomes not a tedious event, but something they still enjoy doing. And can we also get the men to bandwagon with us? We seem to be leaving them behind all the time. I won't go beyond there. I want to just appreciate all the participants too, and also the rapporteurs who are in the back end, actually doing the rapporteuring summaries. Would like to also appreciate the ICT, and we look forward to tomorrow. It's the last day, but it's not the last event. There's still a lot more to be learning and to gain from attending. So thank you very much. God bless you all.
Thank you, and Kwaheri.
Bye.